So, good afternoon, everyone. We are going to start the prestigious Colonel Rangachari session, and I'll just welcome all the judges. They are already on the dais. I'll speak Dr. A.K. Grover, Dr. Rajiv Raman, Dr. J.S. Titiyal, Dr. Shri Ganesh, Dr. Radhika Natarajan, Dr. Natasha Pahuja, Dr. Mayuri Khamar, Dr. Meena Chakravarti, and Dr. L. Vijaya. So this is going to be presentation of 6 minutes, followed by 2 minutes for questioning. And per candidate, the maximum marks and the minimum marks are going to be deleted to remove any kind of bias, and the middle marks will be taken to have a fair contest. So I'll request the judges to please start, sir. Yeah, I'll call the guy. Dr. Kasturi Bhattacharya also.
See that maximum and minimum, suppose there's one candidate who has done exceedingly well and most of the judges have given him the highest marks, and you remove that, then he'll be out of the race, which is not ideal.
No, uniform हो गया ना उसका, फिर तो that will be taken as a
सबका ही बराबर आ रहा है सर, फिर तो हटेगा ही नहीं ना, वो तो वही रहेगा maximum में. If 9 out of 10 has been given by all the judges, then that's not going to be removed. If it is vast difference, only one 9 is there and others are giving 6 or something, then that is removed. That's what Dr. Titiyal meant, I think.
No, because,
right, sir?
Because you said in each the maximum and minimum will be removed, na? For each of the judges, the maximum and minimum.
No, not for each judges, for each candidate, sir.
Each candidate.
For each candidate, not for each judge, sir. Right. I also welcome Dr. Kasturi Bhattacharya onto the dais. Yeah. Sai?
I think we'll have an opportunity to leave also. So many judges. Is it? Chai pine chal rahi hai. Khana kha liya?
Yeah.
I was first.
So the first contestant is from Bihar Ophthalmological Society. Miltefosine related keratitis, clinical characteristics and management by Dr. Rakhi Kusmesh, and the specialty is on cornea.
Excuse me, can I have a pen or pencil?
Yeah. Shall I start?
Can we start now? Are you ready with the timer? Okay. I think we can start now. Rakhi, you can start your presentation.
Good morning, everyone. Here I am presenting multifaucet-related keratitis, clinical characteristics and management. I have no financial interest in the subject matter. Miltefosine, a phosphocholine analog that is originally developed as anti-malignant drug, and it has been recommended by WHO to treat all types of leishmaniasis since 2002. And since then, it is first and is still the only oral drug that can be used to treat Kala Azar and its dermal sequelae, that is dermal leishmaniasis. Kala Azar, as we all know, it's caused by Leishmania donovani, and in 10 to 20% of successfully cured cases, the patients develop post-Kala Azar dermal leishmaniasis, which is a potential source of Leishmania infection, and it is characterized by skin rashes. In Bihar, its prevalence is ranging from 4.4 to 7.8 per 1,000 population in Bihar. The recommended doses of miltefosine for PKDL is 100 milligrams per day for 84 days with very minimal adverse reactions like gastrointestinal symptoms. However, there are recent reports documenting the serious corneal complications in patients receiving miltefosine. Although these reports have highlighted the corneal complication, the clinical impression of this entity varied in all the reports from Murren's ulcer to scleritis, and little is known about its clinical course and management. So in this study, we describe the diagnostic clinical features, progression and management of multifaucin-related keratitis in 6 patients. This study was done retrospectively from April 2018 to December 2021, including 6 PKDL patients receiving multifaucin, and this study was approved by IEC and written informed consent was obtained. The evaluation included complete medical history focusing on the drug used to treat Kala-Azar and PKDL and documentation of dose and duration of treatment, and the onset of keratitis after initiation of drug was documented. We also performed the casualty assessment of ADR to multifaucin by WHO UMC criteria. All keratitis were worked up, including size, location, pattern, extent and depth of the infiltrates, presence or absence of hypopyon and epithelial defect, including edema and corneal thinning. And all corneal specimens were subjected for the direct smear examination and culture, and PCR was done to rule out Leishmania donovani in the corneal scrapings. RK39 and skin biopsy was done in all the patients to confirm the diagnosis of PKDL. Results of all 6 patients, the case 1 was bilateral keratitis. He was receiving multifaucin for 48 days and he continued taking this drug for another 17 days after appearance of ocular complaints. On the day of presentation, the picture was, there was a paralimbal full thickness infiltrate in both the eyes with hypopyon, and we suspected an infective organism since we were not aware of the manifestation of this drug. So we started fortified antibiotic and still after starting antibiotics, the patient, the ulcer was progressing very rapidly, involving the center and resulting the corneal thinning, for which patient had to undergone for the PK. And left eye, and since the microbiological reports came negative, we started steroid, oral and topical, and patient left eye responded very well with 6/12 vision. In the second patient, the case was again bilateral keratitis, multifaucin for 35 days, and he continued medication for another 20 days after appearance of ocular complaints. And the picture was very classical. The ring infiltrate the full thickness ring infiltrate rapidly extending to the center as well as circumferentially, for which right eye was operated for PK and left eye responded very well to oral steroid and topical with 6/9 vision. Next 4 cases out of 6 were unilateral keratitis, and they were also taking multifaucin from 38 days to 65 days. And one thing was common in all, that they just stopped the multifaucin after appearance of ocular symptom, and they responded very well to topical steroid with good vision. So results, ocular symptom were pain, watering, photophobia, keratitis, ring shape, full thickness, paralimbal infiltrate. 2 cases were bilateral and 4 unilateral. Laboratory test shows positivity only on RK39 and skin biopsy test. Management, discontinuation of drug and initiation of corticosteroid, and WHO UMC criteria showed the probable association between ADR and multifaucin in all the patients. So we found a consistent pattern of keratitis and its course in all the patients receiving multifaucin, and on the basis of our results, we could divide this entity into 2 stages. Early stage where the ring infiltrate were present and there was an intervening clear zone between limbus and the lesion, and at advanced stages the infiltrates extended to the cornea as well as the circumferentially, leading to a ulcerative keratitis appearance. Mechanism of keratitis is not very clear. It has been documented that the drug might be directly toxic to the ocular tissues, and management is stopping the multifaucin, excluding the infectious etiology, initiating the early anti-inflammatory therapy, and deferring PK in a complicated cases. So in conclusion, this study indicates a prolonged use of multifaucin might cause keratitis, and early diagnosis with discontinuation and initiation of corticosteroid are key to successful management. And this study also emphasized the need to strengthen the pharmacovigilance program in endemic areas, and patients who are receiving multifaucin should undergo periodic ocular examination by an ophthalmologist. These are the references. Thank you.
Thank you very much for your presentation. Who's going to discuss? Dr. Grover, sir?
How does the description or the observations differ from the previously available literature on this?
So there are 4 reports already have been documented, and in all the cases, first case reported that the lesion is just focal in the superior temporal quadrant. Another study documented it as a Murren's ulcer. Next to a study from the Bangladesh.
Are those case reports or are they number of cases?
They were case series basically. They were case series. all were case series.
The question that I have for you is, first of all, congrats to making it to the finals and a very nicely collated presentation.
Thank you, ma'am.
So, since you postulated that it could be direct drug toxicity or immune mediated, as shown by the peripheral nature of the problem, did you investigate these patients to rule out any underlying autoimmune disease as well, which miltefosine has potentiated, number one? And number two, if it has behaved like Murren's ulcer, I see in most of your patients the central cornea was spared. So while doing the surgery, why did you opt for a PKP? Why did you not do a patch graft or an annular graft in these cases and save the central cornea?
What was the first question, pardon?
My first question was, did you investigate them for any underlying immune disease which miltefosine might have potentiated?
We examined all the patients, systemic examination was done, and all patients were immunocompetent without any concomitant systemic illnesses. And it was also examined by the medicine people.
So that should have been mentioned in your presentation because it is a very relevant point.
Yes, okay. And the second question is, in first patient who presented to bilateral keratitis, the central cornea was also thinned out during the progression of ulcer. It was so rapidly extending. So that's why we chose PK in the first eye. And in the second eye, the peripheral cornea was very thin, and it involves the whole 360-degree part of cornea, and that's why we choose to do PK, because we were not aware of this condition, like steroid is very good for these patients.
Thank you very much. Professor Dithyal?
Thank you, Raki. Looking into this, ocular complication coming up, would there be some sort of prophylaxis and treatment for these people to prevent this happening? As Dr. Radhika talked about, if we can pick up some sort of immunological process happening, so should we give them some other treatment like a steroid to begin with the treatment?
As we followed up this patient for so long, and we found that this keratitis appears only after 1 month. Taking the average of all the previous study and our study also, the average is coming 30 to 42 days. In our study, it is 48. So after 1 month, they need a good examination by ophthalmologist, as well as if the drug has to continue for this entity dermal leishmaniasis, then we can start a low dose steroid under supervision and IOP monitoring.
I think that should be the way forward, because you have such a high incidence, so we have to look for this prophylaxis also.
Yes.
Thank you, Raki. Wish you all the best.
Thank you so much, sir.
For a Pagentis, it is for 6 minutes, and you will hear a beep at the end of 5 minutes. That means you are left with 1 minute, and make sure you finish within the time.
Dr. Nikhil Balakrishnan, please. On that podium. Yeah. Dr. Nikhil Balakrishnan, and his title is Baseball Bat Sign, Predicting Prevalence of Intraop Floppy Iris Syndrome in Patients on Tamsulosin.
Good morning, everyone. My topic for today is a baseball bat sign predicting the prevalence of intraop floppy iris syndrome in patients on tamsulosin. I have no financial interests. So what we already know is that benign prostatic hyperplasia is a common condition in elderly males with a very high prevalence as you go higher in the age group. We also know that the treatment of the same is in the form of giving alpha blockers, which helps to relax the smooth muscle of the prostate. But the side effect of the same is that it acts on the receptors on the dilator pupillae. Now, it is very well documented that when the alpha adrenergic drugs act on these, it causes something called as IFIS, or intraoperative floppy iris syndrome. As Dr. Chang has already published, it mainly consists of insufficient pupillary dilation, undulated or billowing of the iris prolapsing into the wounds, and progressive intraop pupillary constriction. But we do not know what exactly is the incidence of IFIS in patients on tamsulosin. Various different studies have published different percentages of this. So our research question was that, is there a perfect method to predict the occurrence of IFIS in patients on tamsulosin? My material method was a case control study. The sample size, a test group that was a patients on tamsulosin greater than 3 months was 76 eyes, and a control group of 76 eyes and patients not on tamsulosin. Age was above 55 years old, male patients only. No other drugs besides tamsulosin was considered. Glaucomatous patients on AGM and complicated cataracts, and any patients who had altered iris morphology were excluded from my study. Besides the routine preoperative examination, we made the patient undergo an undilated anterior segment OCT and an infrared pupillometry. So from the OCT, what we actually assessed is the iris structure and pattern, and using the pupillometry, we assessed the pupillary diameter under both photopic and scotopic lighting. Now, this is the iris measurements. Here you see the scleral spur and the pupillary margin. Exactly midway between the two is the dilator muscle region, and 0.75 millimeters away from the pupillary rough or the pupillary margin is the sphincter muscle region. So, and we also did the pupil measurements using both photopic and scotopic pupil using the correct lighting conditions. Now, we also then checked for the incidence of IFIS intraoperatively while the surgeon operated in all the cases. So, what were the results of our study? There was no age differentiation between the two groups, but we did see a significant decrease in the dilator muscle region thickness in the test group as compared to the control group. There was no significant difference in the thickness of the sphincter muscle region area, and there was an altered DMRT versus SMRT ratio. Now, this is the thing in the control group, as we see here, the dilator muscle and the sphincter muscle region area thickness is more or less similar, whereas in the test group, the dilator muscle region thickness is almost 0.75% less than the sphincter muscle region thickness. These are the photographs of different patients of the same. So because of the striking resemblance of the iris of these patients on tamsulosin, we coined the term as a baseball bat sign. There were also marked differentiation. That means there was decreased photopic pupil size in the test group as compared to the control group. The scotopic pupil size also was markedly reduced as in the test group as the control group, but there was no difference in the ratio between the photopic and the scotopic pupil. Now, how did this correlate intraoperatively? In the control group, none of the patients developed any signs of IFIS. In the test group, 62 of the 76 patients had one of the signs of the IFIS at least, that is either floppy iris prolapsing into the wounds, or an intraoperative pupillary constriction. So what is the conclusion of my study? A use of the baseball bat sign, that is the thinning of the DMR thickness of the iris on the anterior segment OCT, is a reliable tool to detect the occurrence of IFIS in patients on tamsulosin. So what new does our study add? It uses anterior segment OCT for predicting the occurrence of IFIS on patients on tamsulosin. It's the first study to demonstrate the thinning of the iris DMR in patients on tamsulosin, and we hence coined the term the baseball sign. And it also demonstrates inadequate pupillary dilation in patients on tamsulosin using infrared pupillometry. So how do we translate this science to our clinics? We would be better prepared if we knew preoperatively that patients are going to be suffering from IFIS. We would create longer wounds, do a more controlled hydrodissection, decompress the chamber repeatedly to remove out the viscoelastic, and do a low-flow phaco too. What is the futuristic approach to overcome the limitations of my study? Now, we need to find a method how to correlate the iris measurements which we've got from the anterior segment OCT into the real iris thickness, and if we could do human cadaveric studies to corroborate the iris dilator muscle region smooth muscle tone deficiency in patients on tamsulosin. Thank you.
Yeah, thank you, Nitin. Wonderful presentation. Dr. Sri Ganesh, please.
Yeah. Nice presentation. I just wanted to know how many of these patients were diabetic?
So we did not consider any of the systemic conditions here as hypertension or diabetes as a deciding factor, as in we did not take that into consideration. They were equally distributed in both the control or the test group. Diabetes was not an exclusion criteria in our study.
So you had diabetes, because
yes.
In diabetes also you can have inadequate pupillary dilatation, you can have glycogen deposition in the iris, and so this can affect the thickness. So
yes.
That is a confounding factor in the study.
Correct.
You should probably exclude diabetic patients. And intraoperatively, did you use adrenaline and xylocaine in these patients?
So the surgeon was not informed about what kind of, this was a retrospectively, we went back and checked that what was the percentage of patients who had both the baseball bat sign and the IFIS symptom. Intraoperatively, the surgeon wasn't aware whether he was operating on a patient of the test group or a control group. So he performed the phaco as in a regular case he would as a routine.
Because on scotopic pupil was 5.6
Yes, sir.
in your test group. So 5.6 pupil, it's very difficult to do phaco. So the surgeon would either use adrenaline and xylocaine or use a pupil dilator.
Yes, sir.
So when you use a pupil dilator, you can't really assess the floppy iris. Or if you use adrenaline and xylocaine, then it again reduces the floppiness. So you can't really assess whether it's actually a floppy iris or not. So ideally, the surgeon should operate without any devices or pharmacological agents. And if he doesn't know, then if it's a small pupil, he will automatically, if it's 5.6 pupil, I think most of us would use either adrenaline xylocaine to try to dilate it or use a ring. So that is again a confounding factor. So this is something that you have to keep in mind.
Yes.
So these are basically the fallacies which I found.
Yes, sir.
I would like to ask a question. You have mentioned that the dilator muscle thickness is less. So what could be the reason? Because you have done a retrospective analysis.
Correct.
And after surgery also there are effect on the dilator muscle.
Yes.
So how do you correlate that this is due to the medicine and not due to the surgery? And what could be the cause of this decreased thickness of the dilator muscle?
So, ma'am, we took the measurements. The measurements were taken on the anterior segment OCT prior to the surgery. It was not taken after the surgery. So what we did is that before, as I said, pre-operatively as a part of the routine cataract investigations, we also did an anterior segment OCT where the dilator muscle region thickness was measured. And then intraoperatively, the surgeon performed surgeries routinely. And we saw what was the ratio of the patients who developed IFIS who also had the baseball bat sign. So we have not taken the post-operative anterior segment OCT to see what was the thickness in that.
That means the surgeon knew that the
No,
patient
ma'am,
is
no. The surgeon did not know that
I was a little concerned about your definition of IFIS as well. You said any one of the three or odd features you took as IFIS.
Yes, sir.
So just the prolapse of the iris, if there is some other factor in construction of the wound or too much pressure used, you wouldn't be able to classify that as IFIS. So I think that needs a better definition.
So we have used.
Thank you, Nitin. It is well understood, this thing. And wish you all the best.
Thank you, sir.
Yeah. Next.
The next contestant is Dr. Parikshit Gogate, and his title is 4-year longitudinal study of 44,535 individuals to see reduction in blindness and vision impairment. And I'll also request the next contestant to be ready. Next contestant is Dr. Santosh Mahapatra. Dr. Parikshit.
Respected judges, distinguished audience, esteemed competitors, this is a longitudinal study that we are presenting. We all know the L.V. Prasad Eye Institute Vision Pyramid. The Alma Ata Declaration in 1978 had emphasized primary health, but it took few years for this to come in eye care. But even though literally hundreds of vision centers have been established in the past 20 years, there is hardly any proper data which shows what difference it has made. So we wanted to examine the eyes and vision of an entire population, a community in a slum in Pune, to set up a vision center in that area and to re-examine that community after 4 years to see the impact of our intervention. We used the Operation Eyesight Universal's technical advice, and 4 trained community health workers did a screening of each and every individual. Those individuals who had vision less than 618, they were referred to the vision center, which was within 2 kilometers of their residence. At the vision center, an optometrist performed a comprehensive eye examination. Those who did not improve to 612 were examined by an ophthalmologist, who also assigned a cause of visual impairment and blindness. But if these individuals did not come to the vision center, then the optometrist went to their homes and using a handheld slit lamp, autorefractometer, tonometer, did the entire examination in the homes. If they felt that an ophthalmologist needed to see them, the ophthalmologist, she also went to the people's homes so that each and every individual was examined properly. And the 4 community health workers, the social worker, one of the optometrists and ophthalmologist were all ladies. These are the age and genders of the 2 cohorts, and we had 44,535 individuals, of whom 43,708 could be examined after 4 years. Some had died, some had moved a few refused examination, and very few were lost to follow-up. And if you will see the OPD, the number of cataract surgeries, the spectacles prescribed, and the spectacle dispensed, there is a female preponderance. Almost 60% of it is uptake by women. If we look at the vision that has been examined, you can see that the prevalence of blindness has reduced in the better eye, as has the visual impairment. But here, women have almost 1.5 times the prevalence of blindness as compared to men. And it's not just the better eye, it's the worse eye, because we have to treat all eyes. Even in worse eye, the shift is even bigger. And if you look at the causes of blindness, cataract, glaucoma, and corneal causes are there on the top. Diabetic retinopathy is not that much. And even after 4 years, cataract is still a significant cause of blindness. I'll come to this later. Same for visual impairment. So what was the impact? We definitely reduced the prevalence of blindness. But even after that, women still continue to have a higher prevalence at both the points, even though the gender gap was narrowed after 4 years. On an average, the population had become older by 4 years, but the prevalence of blindness had reduced. We attribute both these phenomena, greater number of people available for repeat eye examination and more women seeking eye care, to the house-to-house screening and the vision center predominantly served by female staff in the community. So the strength is, of course, more women accessed. They got comprehensive, reliable service. The service paid for by itself. The initial outlay was from our private paying patients. It's done by a single small clinic. We gave person-based individualized care with health education and promotion. But then it's costly in terms of human resource. And of course, we did not measure inter-observer variation of the CHWs. And if you look at all the studies that have been done earlier, all of them are based on stratified random sampling. This is a study in which we have examined the entire population, the entire universe, and we have come to the result. And of course, it is a tribute to us Indian ophthalmology that if we had 1.34% as the prevalence of blindness in 71, even in a slum in Pune, which is a relatively better off, it is today just 0.21%. That's less than the WHO's goal for 2020. And of course, this primary center is linked to a secondary and tertiary center, and it has to be linked back also because for low vision rehabilitation, again, we have to go back to the community. We all know vision is needed for economic independence, social interaction, for enjoying life, because finally, healthy eyes lead to happier life. And this is what we all try from our side. But then access is just not important. A lot of our findings were with the Andhra Pradesh IDC's 3 studies. But we know even in urban slums or poor, the priority to healthcare is less. And traditionally, we had 4 barriers for cataract surgery: lack of awareness, bad service, cost, distance. But here we have a center. We have gone to each home. They know they have a cataract. We gave earlier subsidized, later even free cataract surgery, good surgery with clinical audit. So cost is not a this. Distance, it is within 2 kilometers of their home. In spite of that, 4 years later, still cataract is a significant cause of blindness. So when we say we want to make this completely avoidable blindness-free, well, there are more barriers to it, perhaps social or psychological barriers, which we have to think of. And of course, even the gender disparity we have to think of. So I would like to acknowledge all the people who helped us with this, and thank you for giving me this opportunity.
Yeah, any of the judges like to make a comment?
Yeah. Congratulations, like your approach to reach the last man in the last mile is wonderful. But I just want to know what additional measures you have taken in order to overcome the barriers. You have mentioned good numbers of barriers. So what are the additional steps you have taken, especially for the females, to overcome the barriers?
Ma'am, one is, I mean, even we were surprised. This is just 3 kilometers away from BJ Medical College or Sassoon General Hospital, which is Pune's, one of 130-year-old medical college. In that 45,000, we found 800 cataracts. And we did the study first year, and for the cataracts, anyone whose vision was less than 6/18, they were followed up every 6 months to see if, so we can't do this in 6 minutes. So we have another study which shows that how the barrier is the first time they go, then the second time they go, the third time they go. But even after 4 to 6 visits, even after 4 years, there are still people who are blind with cataract, even though we say, okay, we will do free surgery for you, but they are still not willing to take it up.
Thank you, sir. So one more thing, you have mentioned that cataract surgery is one of the way of mitigating the barrier. So what about spectacle dispensing amongst these females?
Ma'am, that was the biggest thing. If you look at the data, almost 58% of the specs prescribed are for women, that's girls, and this we have the adult and the children breakup also. And almost 57% of them purchased are also by females. And so if you look at the barriers and the causes of blindness, refractive error is not a cause of blindness because we have been able to address that. Even cataract has reduced, but it has not been illuminated. Even the refractive errors, it's still there, but it's very less.
Thank you.
Thank you, Parikshit. Just one look into your study, which is sort of taking care of one particular community for a long term. And I think that will be the way ahead. If every ophthalmologist takes, one particular area, then that will, as you said, that will not require that RAP survey. Then we'll have a complete this thing. One thing I'd like to know in that community, what was the education level, because that will translate into the what you are trying to say.
So we do not have the Kupuswamy scale. We have it only for the cataract, but it is a lower middle income group. There are some communities which are like very, very poor, but they would be about say 4,000 or 5,000 in that 45,000.
Because education and the economy both goes together in terms of eliminating blindness in our country. Thank you, Parikshit.
Thank you, sir.
Just one comment. Really great work. I think 4 year having only 20%, nearly 20% dropout, I think, was about 10,000 didn't come.
No, sir. Only 3,000 didn't come. No, it's not that they didn't come. We had to go to their home. So the question of them coming was not there.
I was just looking at these people who were on dropout, whether they had undergone any procedure in the first visit, because they didn't come in the last 4 years.
So there were only 181 which are lost to follow-up. 222 have died. Only 28 have refused a repeat examination. So,
yeah, great.
Thank you, sir.
Dr. Santosh Mahapatra, and after that, Dr. Pradeep Sagar to be please ready. Dr. Santosh Mahapatra.
Good afternoon, everyone. I am here to present 52-week results of safety and efficacy of optogenetic therapy for vision restoration in advanced retinitis pigmentosa. I am the principal investigator for this study, but I have no financial interest, and the documents related to ethical clearance are submitted to the scientific committee AIOS. So why optogenetic gene therapy? It's because the available therapeutic options like putting of electrodes are invasive in nature and has limited resolution. Then classical mutation-specific gene therapy requires presence of photoreceptors, and in advanced RP, most of them are lacking it, and hence the need for optogenetic therapy. So what is optogenetics? Optogenetics is introduction of special gene that enables the neurons to be stimulated in response to light, and it converts that specific neurons to photoreceptors. Earlier, monochromatic options were used, which required intense light and use of goggles, but it produces suboptimal neuronal stimulation. Hence, in this multi-characteristic opsin is activated in ambient light and generates significant photocurrent without need of the glass. So the target cells are bipolar cells, and this MCU is delivered into the vitreous cavity by simple intravitreal injection and targets the bipolar cells, which are convertible to photoreceptors. So this is the way of study, and the key enrollment criteria was either perception of light or hand movement in the study eye, and no better than counting finger in the fellow eye, regardless of the RP gene mutation. The study population divided into 3 cohorts. The first 3 received 1.75 into 10^11 vector genome, and after testing the safety and efficacy, we went ahead for the next cohort, which received 3.5 into 10^11, and the next 5 received the same dose. There are 6 males and 5 females in the study, ranging between 18 to 70 years of old. And this is the study design showing the schedule of events from 1st to 52 weeks. On 4th week, there was neutralizing antibody test in serum of all patients who received VMCO, and none of the patients developed neutralizing antibody. And the gene panels showed the most common gene was ABCA4, which was detected in patient number 5, 8, 9, and 10. The safety was proved by the fact that no subjects developed more than 2+ AC or vitreous inflammation. 5 out of 11 subjects required no medical treatment. 2 out of 11 had mild to moderate intraocular inflammation. 5 out of 11 had moderate IOP rise, which are well controlled with topical medications. And no subjects required oral steroids or glaucoma therapy. There was no detectable retinal toxicity, which has clearly shown on the fact that nobody had retinal detachment, cellular growth, or macular edema throughout the study duration. The fiber visual acuity shows improvement of more than 15 letters in 7 out of 8 subjects and more than 30 in 6 out of 8 subjects. The MCO gene expression was measured by fundus autofluorescence with M-cherry as the marker, and it is maintained till 52 weeks of the study. So the Y mobility score improved after MCA injection, which are plotted for all groups, low dose group and high dose group throughout the study. And this is one of the representative videos where a patient is asked to move towards the illuminated light of 1 lux in a Y mobility test, and you can see the way the patient is moving on instruction by the, and he is not able to find the light even after taking a lot of time. This is 16-week post-injection, and the way the patient moves in the Y mobility and the way he is able to find the light with perfection can be seen. So to summarize, the study safety profile was favorable with no serious adverse events. Mild increase in IOP and ocular inflammation were well controlled with topical medications. There was no increase in neutralizing antibody to the MCO in serum, suggesting no systemic immune response. And the dose-dependent efficacy response at 52 weeks after single intravitreal injection of MCO was proved by improvement in fiber visual acuity and other efficacy endpoints like multi-characteristic less error and time on visually guided Y mobility tests, increase in visual field index, improvement in discrimination of shape and optical flow direction in LVMPT, and increased NEI visual questionnaire. With these results, a randomized double-masked controlled multi-center trial is going on in US at 7 centers with FDA approval, and I would like to thank my co-investigators for this wonderful study. Thank you.
Thank you, Dr. Santosh. Wonderful presentation. I would request Natasha if you have some questions to him. Or Dr. Meena.
You have followed up your patients for a period of 52 weeks after
Now,
the year. Yeah. How long would you expect the effect of this therapy to last? Are there any other studies done previously?
No human studies. This is the pilot study
First
which was conducted.
study.
They have already done in mice and dog, and the data is already published. And depending on those studies, the dose of the intravitreal, we have tried to tailor it out by 3 different doses we wanted. And we have seen the patient till 2 years, since in October 2020. Because of the COVID, we complete the study. We have enrolled 12 subjects, 1 opted out. 11 subjects were seen till 32 weeks, and between 32 to 52 weeks, 8 subjects were seen, completed the study without any adverse effect. And we have also seen the 2-year follow-up following COVID in October 2020 without showing any systemic adverse effect. And the the effect of the drug is still continuing. They are able to move outside when they are asked to move in a corridor or in a staircase. They are able to move. I have video recordings for those also, but because lack of time, we could not give all the.
Did you do any electrophysiological test like
Yes,
ERG?
yes, we did electrophysical test.
Was there any
but
difference?
yes, sir, I am explaining. Because of very low fixation of the patients, you need to have a waistline first, and following injection, you need to graph it out again. Because of very low fixation, because the nature of disease and amount of vision they have in the range of light perception of or hand movement, we directly could not extrapolate the data because of the graphs were very inconclusive.
Okay. Thank you very much.
Thank you.
Next.
Yes, sir, you can ask me.
Just
Please. Yeah.
It's a good study, good phase 1, and mainly you were looking at safety. Did you find any correlation with the gene, because you had maximum ABCA4? Though ABCA4 is not a very common for RP. No, how did you find any correlation?
No. We saw that most, in spite of the variation in genes, there is no specific gene which is showing more or less.
I didn't understand how you did the MCO expression on autoflows.
Yes.
Will just give you the
No. In human eyes, it is not demonstrable. It is already demonstrated in dog eyes by immunohistochemistry. And in human eyes, if you do a red fluorescence, you can detect it, still to come.
Toxicity you looked into by autofluorescence also, what was the change? Because I fully understand electrophysiology, there is already extinguished response.
Yes.
You may not get by ERG, but
Yeah.
other tests like EOG or a VEP, because you are also concerned about the nerve toxicity. This is a drug you are trying first time, or the method is first time.
Yes, sir.
Be keen to know VEP, EOG.
We are planning to introduce those things in phase 3, because phase 2 with the same, the FDA accepted for the phase 2 with the data from the pilot study. So you cannot add more criteria to the phase 2. After phase 2, then we may again apply to FDA, and with incorporation of new parameters, we can come with phase 3. Thank you.
The next contestant is Dr. Pradeep Sagar, and after that we'll have presentation by Dr. Kasturi Bhattacharjee. She has already won Colonel Rangachari medal in 2008, so it is just for the presentation's sake and not for competition.
Okay, you can start, Pradeep.
Good afternoon, respected judges and the audience. My topic for today is targeted laser photocoagulation of capillary macroaneurysms with rim in diabetic macular edema. It's not moving. The topic for presentation is targeted laser photocoagulation of capillary macroaneurysms with rim in diabetic macular edema.
Reset the time, please.
The topic for my topic is targeted laser photocoagulation of capillary macroaneurysms with rim in diabetic macular edema. We know that microaneurysms are the earliest clinical finding in diabetic retinopathy, and the leaky microaneurysms contribute to diabetic macular edema. Microaneurysms are typically smaller, but aneurysms which are arising from the capillaries but larger than the normal microaneurysms are described in literature with various terminologies such as telangiectatic capillaries, retinal capillary macroaneurysm, and it is documented that they are better visible on indocyanine green angiography and infrared reflectance image, which is not easily available with most of the clinicians. So in this presentation, I will be describing a clinical way of identifying a capillary macroaneurysm. That is, here we can see that an aneurysm surrounding which there is a wide trim, and in OCT we can see that it is composed of a hyperreflective rim with a hyporeflective lumen, which confirms the presence of an aneurysm. In a retrospective data, we identified that the diabetic macular edema due to these capillary macroaneurysms with rim respond poorly to anti-VEGF therapy. So the purpose of this study is to assess the efficacy of targeted laser photocoagulation in the management of diabetic macular edema secondary to the capillary aneurysms with rim. This was a retrospective study in which we included diabetic macular edema in which the cases had capillary aneurysms with rim within the edematous area, included both the treatment naive eyes and eyes with poor response to intravitreal therapy. So capillary aneurysms with rim were identified by a good clinical examination with slit lamp biomicroscopy. It was documented on color fundus photograph and reconfirmed on optical coherence tomography. A 532 nanometer double frequency Nd:YAG laser was used. The spot size varied from 50 to 100 micron based on the size of the aneurysm. The endpoint was the complete blanching of aneurysm. They were followed up every 4 weeks until the resolution of edema and every 3 monthly after the resolution of edema. So we included 10 eyes. I will just describe each case. We can see that in this case 1, the patient responded poorly to multiple doses of anti-VEGF bevacizumab, and here we can see that there is an aneurysm with a wide trim. And post-laser, after 2 months, we can see that it is completely sclerosed, and we can see that it's completely obliterated on OCT, which is in the form of a uniform hyperreflectivity. And we can see that the macular edema had completely resolved, and there was no recurrence for the last follow-up till 6 months. Case number 2, the patient was initially treated with multiple doses of bevacizumab and dexamethasone implant with no response. Here we can see that there is an aneurysm with a rim. 2 months post-laser, we could see that the cavity was completely obliterated and there was a complete normalization of the foveal contour, and there was no recurrence till the last follow-up at 24 months. This is the other eye of the same patient. In this eye, we considered laser as a primary therapy considering the success with the other eye. So here we can see that there is a complete obliteration of the lumen and a normalization of the foveal contour. He had a recurrence at 18 months due to development of a newer capillary aneurysm with a rim. Case number 4, laser therapy was considered as a primary therapy. Here we can see the capillary aneurysm with a wide trim. Post-laser, 2 months, we hardly see an aneurysm. We can see that it's completely obliterated on OCT and the macular edema has completely resolved compared to the initial. And there was no recurrence till 6 months follow-up. Case number 5, again a similar case in which we can say that there is a complete obliteration of the aneurysm. There is a complete resolution of macular edema and obliteration of aneurysm. Here we can see that this is the post-laser 1 month, there is a complete resolution of macular edema and no recurrence till 4 months follow-up. Case number 6, a similar response, complete obliteration of the aneurysm and a normalization of foveal contour. Case number 7, here we can see that there is an obliteration of the aneurysm, but the subretinal fluid has resolved, but there was a persistent of intraretinal cystoid space. So case number 8, here we can see that one of the aneurysm is completely occluded, but the other aneurysm still shows a cavity. There was a partial response. Case number 9, there was no improvement in macular edema in spite of a complete obliteration of the aneurysm. Case number 10, here we can see that there is an aneurysm over here with a surrounding intraretinal hemorrhage. Post-laser, the hemorrhage actually increased, but there was no change in the macular edema. Rather, there was a minimal increase by 3 months of follow-up. So out of the 10 eyes, we could see a complete resolution of macular edema and a long-lasting resolution in 6 cases, and a partial resolution in 2 cases and no improvement in 2 cases. Aneurysm could be completely obliterated in 9 eyes. So the limitations of the study are its retrospective, small sample size, variable follow-up duration, and long-term risks are not assessed. To summarize, capillary aneurysms with rim are seen in diabetic macular edema. It may be associated with poor response to intravitreal pharmacotherapy. It can be identified by a good slit lamp biomicroscopic examination and confirmed on optical coherence tomography. Targeted laser photocoagulation results in good response in good proportion of cases. So it should be identified and a laser photocoagulation should be considered in such eyes. Thank you.
Thank you, Dr. Pradeep, for your presentation and study. Dr. Meena would like to comment.
Thanks for the good presentation. A good presentation. You have put together the cases quite well, but do you feel that so much thickening of the retina could be because of this unifocal single lesion that you see? And did you combine your targeted laser photocoagulation with anti-VEGF injection?
No, ma'am. All these cases are single monotherapy, sir. Monotherapy with laser. It was not combined with any anti-VEGF or any steroids.
So you personally feel that that single lesion has leaked so much and caused so much retinal thickness?
Based on the observation, it looks so, but the major thing is like we came up with this plan mainly because of our results of a previous retrospective study in which we noted that these aneurysms were seen in close to 12% of cases in diabetic macular edema, and they responded quite poorly to anti-VEGF therapy. Here we can see 2 cases here in which there was no response, absolutely no response to anti-VEGF therapy. Based on that observation, we considered laser as a primary therapy in such cases, and only the aneurysm was lasered, ma'am.
So your take-home message is that if you see a rim aneurysm, you treat it only with laser.
Yeah, just one question. A very good study. It's well documented, already known that these are the ones which cause the non-response. My question is that, though again, the gold standard of identifying these microaneurysms are by doing ICG, because these are fibrin-filled microaneurysms which are picked up more on ICG. You picked up on a clinical picture, that red color with a white rim. How many of, because you did a OCT also, how many of them had these type of ring but didn't have the clinical picture of that rim? Because it's not like all of them will present like a rim-like. Because the take-home message you are telling is, without doing a ICG, pick up these by a fundus photo or a OCT. So could you see how many of, because you had both, how many of them didn't had the clinical picture of that ring-like?
Sir, in this study, actually, we have included only the eyes with rims, sir.
Okay, so that was your inclusion criteria.
That was the inclusion criteria. We have included only the eyes with rim.
The second thing, you need not wait for 3 months for seeing the obliteration. Actually, what we do is we do it immediately so that you see that obliteration immediately after laser. You know that it has worked. It doesn't take 3 months for the obliteration to come.
So what the image, whatever we have included is at the time of resolution of edema. We have followed up every 4 weeks. We have done the OCT.
Use it to guide your treatment, because these are bunch of aneurysms.
Yes, sir.
Whether you have treated it correctly or not, immediately you can do OCT. If you have obliterated, means you have treated that.
Yes, sir. Yes, sir.
Good study.
Thank you, sir. Thank you.
So the next presenter is Dr. Kasturi Bhattacharya and Bhattacharya, and after that, Dr. Prithvi Chandrakant.
Respected seniors, my colleagues and my friends.
I'll just a minute, and this is not for competition. Yeah.
I'll be speaking on platelet-rich fibrin as a three-dimensional scaffold in surface-owned healing of the eye and orbit. No financial disclosures, no conflict of interest. We all know that platelet-rich fibrin, also the PRP, is a second-generation biomaterial wherein autologous platelet and leukocytes are present in a complex fibrin matrix to accelerate the healing of the soft and hard tissue and used as a tissue engineering scaffold. We all know that during tissue reparative process, there are a wide range of intra and extracellular proteins and growth factors which regulates the healing process. So though the understanding of this entire process is very complex, however, platelets does play a crucial role not only in the hemostasis but also in the wound healing. This PRF serves as a simple, non-toxic, biocompatible and economical therapeutic alternative which bears the potential for steady local release of growth factors, making it a holy grail for the future medical and the pharmaceutical research. PRF is a second-generation fully autologous biomaterial having lots of growth factors like the platelet-derived growth factor, the fibroblast growth factor, the transforming growth factor, the VEGF, the epidermal growth factor, insulin growth factor, and the mesenchymal stem cell. These, along with the fibroblast and the leukocyte, forms a matrix, and then it entraps and causes sustained release of the mesenchymal stem cell, thereby preserving its paracrine function. So the aim of the study is to evaluate the PRP as an adjuvant in the surface healing of the eye and the orbit. This is a prospective non-comparative intervention study where 16 patients were included, 8 with a contracted socket, 2 with non-healing lid fistulas, 2 with wide conjunctival granuloma, and 2 with lid cicatrization. Following reconstruction, the PRF was incorporated as a layered surface adjuvant to the bare wound, and the wound healing was assessed by the wound evaluation scale, which is a validated scale by the American Academy of the Trauma. So this PRF, how it is made, the blood is taken from the patient and the cloth activator-free vacutainer is being used, which is centrifuged at 3000 RPM for 30 minutes. And this is what we get. The first 2 millimeter is a PPP, that is the platelet-poor plasma. Then we get the platelet-rich fibrin, and then we discard the RBC. So the follow was as per the prefix pro forma at day 1, day 7, 1 month, 3 months, and 6 months. And the own evaluation score included the 6 attributes, mainly the step of borders, the contour irregularity, the scar width, the edge inversion, inflammatory changes, and the overall appearance. Score of 6 is considered the best, and the score of 0 is considered the worst. Once PRF is obtained, acellular plasma can be squeezed out to yield the resistant autogenous fibrin membrane. It can be folded upon itself to obtain a multi-layered fine flexible fibrin matrix. In addition to the concerned surgical intervention, the PR membrane was laid as a layered adjuvant to catalyze the wound healing. As mentioned, the wound evaluation scale has been used. So this is how the PRF it comes. So once you have the blood being taken and being centrifuged, so this comes as a membrane. It is very useful. I feel in future it can replace the amniotic membrane and even the mucous membrane that we are taking. And this is like one of a lead cicatrization which was very difficult. A full lid blepharotomy has been done and then PRF has been used. And depending upon the size of the test tube, if the test tube is 2 millimeter, we get approximately 1 centimeter thickness of PRF. If the test tube is 10 millimeter, we get approximately 4.5 millimeter width of the PRF. So if we take a 10 cc of blood, at least we can get 5 PRF sheet like this, which can be very nicely used as for the reconstruction of the cicatrization and as user posterior lamella. So these are some of the indications where PRF has been used for the socket reconstruction besides the lid reconstruction. So the results at the end of the 4 weeks showed that 12 had a very good healing and 2 had a moderate healing, and both these 2 patients had a lid fistula with chronic excessive granulation tissue. However, the wound healing was very good in all the socket. However, at the end of the 3 and the 6 months, we found that all the patients had a very effective wound healing. Thus, in discussion, I'd like to mention that PRF, by virtue of its slow polymerization, confers an intrinsic structural scaffold for incorporation of the platelets, growth factors, cytokines, leukocytes, and the stem cells. It is an autologous, so very economical and easy to synthesize, and it can present as a physiological 3-dimensional fibrin reservoir for the cytokine enmeshment, cellular migration, and sustained release of the growth factors. To the best of our knowledge, by different search engines like the PubMed, the Google search, the Science, Direct Scopus, etc., this is the first of its kind to showcase the utility of PRF as a prudent physiological fibrin reservoir that can expedite wound healing in surface reconstruction of the eye and orbit. Thank you very much for your patient hearing.
Thank you very much. I think we'll ask the question later. We can invite because he's the judge. So
no, I'll just make one comment. Healing was excellent, but we need to have some controls in order to say that this is different from any other patients. Of course, these are difficult cases. They did well, which are very encouraging results.
Thank you.
Yeah. So the next contestant is Dr. Prithvi Chandrakant, and after that, Dr. Pragya Saini to be ready.
Yeah. Good afternoon, everybody. I'll be talking on smartphone gonio imaging. So as we know, glaucoma is the second most cause of blindness after cataract, and it is the leading cause of irreversible blindness. And in India, it has a prevalence of 11.9 million with the equal proportion between open and closed angle. And there are numerous studies saying how screening is very essential for early stage diagnosis. And one of the most integral part of glaucoma screening is anterior chamber viewing or imaging, which decides the diagnosis and management later. As we know, the only way of doing gonio imaging is right now with the slit lamp. Although there are few new discussions on smartphone being used, there are no studies proving that or comparing it with the slit lamp. Over here, we are going to tell you how a frugal imaging system can be done with an intraocular lens and just a smartphone. So this, you can actually take just your AIOC badge if you want, and you can make this a simple device. There are the holes also marked in this. The only thing you require is a double-sided tape which like the one shown over here, and then intraocular lens of 6, 8 or 10 diopters, which can be put in between this and sandwich it and close it, and your device is ready. This is called Aspigonio, and this device has been stuck to the primary camera of the phone. Over here we're using a 5S basic phone. So this actually converts a smartphone into a macro lens and gives you a well magnified image of the gonio angle structures, and it can be used in any phones. And we did a comparative study with the 120 patients within 1 month in the general OPD with 20 years and above, both males and females. The exclusion criteria was corneal pathology and edema, because it would hamper with the image quality. Routine examination was done and the images were obtained from the slit lamp, and even the Aspigonio images were taken with single mirror. We found out that we actually made a pilot study in which all the 1 mirror, 2 mirror, 3, 4, we compared it, and we found that the single mirror would actually work best with all our Aspigonio. We used a smartphone with the periphery camera and the central camera, and found out that it would be better for us to have a simple basic peripheral camera. So we took the iPhone 5S. Also, we took 8 diopters. We had compared 6, 8 and 10, and we found out 8 would be best for the study. So we standardized everything and took images, and all these images were randomly then given to a medical officer for image quality grading in an iPad. As you can see, there are these 2 phones which we use, central camera facing and peripheral, which could be done sitting and supine. Also with diffuse light, and also with light like slit light, which you could get it from the slit lamp or from a direct ophthalmoscope or a retinoscope. And you can see how the image quality is. Many of them actually mistake it with the slit image itself. We can see silicone oil bubbles. This is also an image taken from the Aspigonio with the slit. Over here you can see this was done with 6 diopters, 8 diopters and 10 diopters, and the distance between the smartphone and the gonio lens. Also the corresponding images taken from each of them. And also these are the similar patient with different lenses. So this image grading were done with respect to noise, sharpness, contrast, diagnostic confidence, artifacts, and blotchy appearance, 1 being the best and 5 being the worst grading. And over here the statistics, demographic, we got 40 to 60 years was a major demographic. And noise, as you can see, the slit lamp image gave us 92% in the grade 1 and 78 in the Aspigonio. Sharpness was more in 95% in grade 1 in slit, and Aspigonio 81%. 93 of contrast, 87 contrast in Aspigonio. Diagnostic confidence was 98% in the slit images and 79 in the Aspigonio images. Artifacts 92 in the slit and 77 in Aspigonio. 96 of blotchy appearance in the slit and 80% in the Aspigonio. The main thing is there's a need of compact health monitoring system, especially in places in small clinical setups, periphery centers, and this is the first kind of study in which image quality of the instrument has been checked. And it's a very easy, do-it-yourself, frugal device. Can be taken, images can be taken quickly and in universal, and also can be used in camps, can be used in vision centers, can be used by teachers to show students to teach as a teaching module, and also for counseling for patients, for laser, and also so basically everywhere. And it is very inexpensive do-it-yourself thing. And the only limitation over here is the sample size was less and we couldn't consider grading. So just want to say that it's a frugal do-it-yourself screening, imaging, documenting anterior chamber, and it is used. Users can be experimented daily practice and places where it is devoid. Thank you.
Thank you, Dr. Vijayavan.
Good presentation.
Thank you.
I have a quick question. In ideal situation, when you do the gonioscopy, you have the small, short slit and dim light.
Yes, sir.
So are you able to achieve that with this, or you need a good light to document it?
Yes, ma'am. Actually, in this study, we were just diagnosing it, whether it was just closed or open angle.
Yeah, you want to say closed angle, you have to do your gonioscopy with a dim light, a short axillary that will not fall on the pupil.
Yes, ma'am.
That is the main criteria to differentiate open angle from narrow angles. Are you able to get that with
Yes, ma'am. Actually, over here we use a diffuse light, but we have started.
There is a flaw to use it as a screening tool.
Exactly.
Did you use the smartphone on the slit lamp also, or did you have a slit lamp, photo slit lamp for taking photographs of?
No, the slit lamp had its own. It was done on a Topcon imaging system. Yeah. That was basically it was an inbuilt
so
slit
the
lamp.
imaging systems have a higher resolution.
Yes.
So you cannot compare that to an iPhone.
Yeah.
You can use an iPhone on the slit lamp. Ideally, you should use an iPhone on the slit lamp and also with your direct this thing, so you can have a direct comparison. Because if you use a high resolution camera, then you always get better photographs on the slit lamp.
Yeah, actually, we wanted to do it with the gold standard, so then we thought of doing this and not the phone per se.
Just one quick question. Go ahead, ma'am.
The diffuse light may not allow you to view above the top of the iris. Hill of the vision will be obliterated with the diffuse light. So false negative will be very high.
Yes, ma'am. We are actually working on that, the same thing.
Idea though is good, but it's not applicable.
For screening, this is basically what I was thinking of screening.
I have a very basic question.
Yes.
You have selected 15 diopter. So what is the size of the image on the corneal plane?
No, it was 6, 8 or 10 diopters that we used in this study. So.
And why not 90 diopter? Then you could have
we are using 19, 20, 25, 15 diopters for all anti-segment imaging. Not for gonio, but anti-segment imaging. This was actually a different modification of reducing the IOL power to, alternate as a slit lamp for the gonio imaging. Thank you.
We can have the next presenter, Dr. Balla, like to introduce, or we should?
So Dr. Pragya Saini is the next contestant, and after Dr. Pragya Saini, Dr. Swati Puljale to be ready.
Good evening, everybody. I'm Pragya Saini, and the topic for my presentation is long-term outcomes following the management of incomplete punctal canalization. Going back to the basics, the punctal canaliculi, they actually develop when between the nasal and the medial and the lateral nasal processes at about 30 mm stage of the embryo, where the lacrimal canaliculi start forming. Initially, they are completely solid structures which start holofying at about 135 mm stage at 6 to 7 months of embryogenesis, and then at 9 months or during the birth time, that's when the apoptosis is complete and they're completely holophied. We don't exactly know the pathogenesis of incomplete punctal canalization yet, but our hypothesis is it's during this hollow apoptosis that is occurring. It's during that time when the incomplete punctal canalization occurs due to incomplete canalization at the punctal level. So we classified it into internal membrane variant and external membrane variant. The internal membrane variant is a membrane which is present just in the internal punctal canal. It is a non-vascular membrane, and on OCT it is seen as a hyper-reflected membrane, and below we can see a hollow canal. The external membrane variant was a little more superficial. In line with the external membrane of the punctum, it was with or without vascularization which was present. Later on in 2014, we found an balloon variant, which was a dome-shaped elevation was present over the puncta. So this is a part of the external membrane, and it's another variant of that. Our methodology was a retrospective intervention study over the 5 years period in January 2015 to December 2020. We used a Nettleship punctum dilator rapid tapering first, followed by slow tapering punctum dilators. Our data included the demographics, clinical presentation, laterality, type of the punctum membrane, associated abnormalities, and management modalities and long-term outcomes. So we first use a rapid punctum dilator to make an opening in the membrane. The slow punctum dilator was done to complete the membranotomy, and on histopathology we saw it as a fibrocellular membrane. On demography, we actually included 98 puncta of 62 eyes of 46 patients, an average age of 12.5, with a female to male ratio of 1:1. So this is the methodology as explained, and here in the end we have like a complete hollow punctum seen on slit lamp. So the patients, they presented with epiphora since birth, about 70% of them. Bilaterality was seen about 35%. All 4 puncta were involved in 16% patients. Both upper and lower puncta of the same eye were involved in 55%. Lower puncta was slightly more, which is 54%, and the upper puncta 46%. The external membrane variant was slightly higher, which was the same as the study published in 2014. And internal membrane was slightly lesser, 38%. 78 puncta of 39 patients underwent membranotomy. Associated abnormalities were seen in 31. So we had 3 puncta who required mini Minoka stenting, out of which 2 required partial canalicular, 2 had partial canalicular obstruction, and 1 had canalicular stenosis. We had 5 patients who had associated CNLDO, out of which 3 underwent DCR for bony obstruction, and 1 patient had a 3-wall canalicular hypoplasia, for which we could not do anything. 3 patients had associated punctal agenesis involving the other punctum of the same eye. And a total outcome, anatomical outcome was 100%, whereas the functional was 97.4. What did the study add was that it validated the earlier management protocols of membranectomy being the primary management, and newer associations like canalicular wall hypoplasia and punctal agenesis was noted. So the insights that we gained was that membranotomy works best if the first puncture into the membrane is performed by a fine dilator, followed by a slow taper dilator. It should be complete membranotomy without any overhanging membrane or residual membrane present. Unlike punctal agenesis, it was not associated with any systemic disorders, and it was rare to encounter functional failure post-treatment. So there was just 1 patient. Thank you.
Thank you, Dr. Grover, sir.
So what was the association, would you repeat that, of canalic, of the punctal membrane with canalicular agenesis?
Could you get my PPT again, please? So, okay. So we actually saw that the other punctum had punctal agenesis present here.
About the association with canalicular non-canalization, how common was that? The punctal.
So only three patients had canalicular
Most
stenosis.
of these were just the punctal membranes.
Yes, sir.
Which
Yes,
could
sir.
be easily overcome just
Very
with
easily.
a punctum dilator.
Yes, sir.
Dr. Pragya, I'm no lid specialist, but being a cornea specialist, sometimes I have observed that in addition to the problems with the punctum and the canaliculus, we've seen in some patients the opposition of the punctum to the globe has been a reason for epiphora. Means the punctum is not flush with the globe, so it's not able to drain properly. So did you find this condition in any of your inclusions? And if so, we found that very difficult to kind of address as a problem.
Ma'am, ours was it was limited to the incomplete punctal canalization. We have had such the problem of lid oppositions and all in patients with punctal agenesis who are completely agenetic and not incomplete in this R criteria. But just these patients do not have such abnormalities. They are absolutely normal, absolute normal caruncle, absolute normal lid margin. And just 1 patient had a canalicular wall hypoplasia for which we could not do anything. But other than that, the lid was completely normal, ma'am.
Okay. What would be the difference in the frequency of the agenesis that you've observed versus the membrane?
Sir, of the 98 puncta that we observed, the agenesis was only in 3 patients.
So most of the cases are just manageable by a punctal dilator.
Yes,
and do not require any snips or anything.
Definitely, sir. And rapid and a slow, so that a complete membranotomy is done, so that there's no recurrence and the membrane does not.
And which cases did you choose to put in a stent?
So there were canalicular stenosis, partial canalicular obstruction where we did trephination followed by stenting, 2 cases of that, and 1 had canalicular stenosis, so we did stenting in that.
And the results in the follow-up, how long have you followed?
Sir, I followed them up for 6 months, 100% normal. And overall, they were followed up for about, like, for the 5-year period, so they followed up the maximum, but on an average, it was 6 months.
Balaji? Thank you, beta.
Thank you.
So the next contestant is Dr. Swati Fuljale, and after that, Dr. Swati Kaliki to be ready on the other podium.
Yeah, good afternoon, respected judges and audience. I am here to present my research work on evaluation of OCT angiography changes in non-arthritic ischemic optic neuropathy. I would like to acknowledge the support of my co-authors for this study. There are no financial disclosures for this particular study we have. So as we all know, NAIN is a common optic neuropathy of elderly population where the site of affliction is mainly posterior ciliary arteries which have hypoperfusion resulting into the ischemic insult of the optic nerve head followed by optic nerve head edema. FFA and ICG have been used to delineate these vessels but unfortunately have been unsuccessful. So OCTA is a non-invasive modality that can delineate these microvascular plexus at different level both at disc as well as macula. So multiple studies have shown that peripapillary vascular loss on OCTA in NAIN patient when compared to the control eyes, papillitis and papilledema. So they have been diagnosed to differentiate these conditions. It would be an interesting thought to explore what happens to the macular microvasculature and what is the effect of NAIN on the macular vasculature in these patients, and also to understand the natural history of NAIN. Maybe this longitudinal study may help. So with that aim to evaluate the longitudinal microvascular changes at disc and macula over the course of 6 months in patients of NAIN. So this was a prospective longitudinal study where after taking the ethical clearance from the Institute Ethics Committee, 15 patients of NAIN were included in the study along with the age-matched 15 control eyes. The criteria for inclusion was 6 weeks from the onset of the symptom. We excluded all those conditions which may affect the retinal vasculature directly or indirectly. Informed consent was obtained and all patients underwent detailed ophthalmic examination including visual acuity, contrast, color, Humphrey visual fields and OCT angiography. The investigations were repeated at 3 and 6 months. So OCTA, we use web source OCT and we scanned the disc with 4.5 by 4.5 mm circle, and the vessels were studied at the level of optic nerve head, where we've studied the peripapillary vessels, then radial capillary vessels, and also the choriocapillary vessels. Similarly, macula was also studied at the level of superficial capillary plexus, deep capillary plexus, and the level of choriocapillary plexus. Once these are just the representative images at various levels at the disc and at the macula. So once we have obtained the image, the quantitative assessment was done with the help of images software, where we opened the image in the images software. We applied the minimum thresholding program to delineate the major vessels. The same image was again opened in a new window where we applied the Falsenker algorithm to delineate the total vasculature, and the number of pixels for each image were counted. So to obtain the microvasculature, we took the total image and subtracted the major vessels from it so that the microvascular is counted, and then it was divided by total number of pixels in the image to get an index. So this was done at all levels for both disc and macula, and we found and results were that the mean presentation from the onset of symptom was around 4 weeks, and almost 12 patients had some or the other kind of systemic association. The presenting visual acuity was very, very poor. When compared to control group, all the parameters at the level of disc and macula showed this significant difference from the control group. The NAIN patient showed the significant difference from the control group. Coming to the OCT8 trends at the level of disc, we found that there was continuous decrease in all the parameters except for the choriocapillaries level, which remain more or less stable. Both the superficial peripapillary as well as radial peripapillary capillary vessels showed decrease, which was probably due to decreased metabolic demand as a result of RNFL atrophy. Coming to macular parameters, we found that all the parameters, although were less than controls at the presentation, at 3 and 6 months, they remained more or less stable. We also correlated these parameters with the visual function, particularly visual acuity, contrast, and we found that the disc parameters correlate well with the visual acuity as well as contrast sensitivity. So to summarize, a significant low peripapillary microvascular density at all levels at the level of at presentation were seen when compared to control group, which is similar to what has been observed by other researchers. And they tend to continue to decrease over a period of time, maybe because of reduced RNFL thickness. Superficial muscular vasculature also show reduction at presentation, however remains stable thereafter, which is similar to what has been observed by Fard and Tau et al. While deep musculature, though not observed by other authors, but except for Astberger et al., we also found a similar result, that they were less as compared to control at presentation and remained stable later on, probably suggesting of some concurrent retinal ischemia, which needs to be evaluated further. So to conclude, OCTA may be a useful tool to delineate the microvascular structure of retina and help in understanding the natural history of NAN. The study is limited by its small sample size, and we cannot exclude the segmentation errors due to the presence of edema. These are my references. Thank you.
Thank you very much. Please.
Nice study.
Thank you, sir.
Just wanted to know, the one limitation which you have told is very, very pertinent, the segmentation error.
Yes.
In presence of edema, especially the deep, which you found and the others didn't find, was probably because of the segmentation errors.
Could be.
How you explain, because how you explain the macular changes which you saw, and what was the progression of these changes?
Yes, sir, that's very interesting. And when we reviewed the literature, we found that only 3 studies are there as far as the macular vasculature is concerned. So out of them, 2 have reported that there's no change. One has reported at superficial level, yes, all of them said that there was some change, but at deeper level, they said that there was no change except for one study. So we feel there could be two hypotheses behind it. One, probably because as a result of optic neuropathy, there is loss of GCL ganglia, GCL layer also, which due to the decrease in metabolic demand, probably the vascular is also affected. The second possibility could be because that due to increase in edema of the disc, there could be a compartment compression kind of a system which is compressing the vessels also at that level. So still needs to be.
You have so many of concomitant abnormalities, diabetes, hypertension, all of them, even without having retinopathy, they cause changes in the vessel density.
Yes, sir, that's a very valid point. But then most of the NAIN patients do have this systemic association, so there is no way we can, take. Yeah. Yes.
Congratulations, wonderful presentation.
Thank you.
I just have an imaging question. You used ImageJ. Did you set up a threshold for it? For the images?
Yes, we first converted into an 8-bit image, and then we used minimum threshold logarithm to delineate the major vessels and Falsenker logarithm to delineate the total structure.
Okay, so in that case, you would miss out on subtle changes along with the edema that you're already mentioning.
Yes.
You'd miss out. So isn't that a limitation of your study, the imaging limitation of your study?
Yes, maybe. Yeah.
Okay.
Thank you.
Thank you.
The next contestant is Dr. Swati Kaliki, and after that, Dr. Pallavi Joshi to be ready on the second podium.
A very good afternoon. So I'll be talking about artificial intelligence in retinoblastoma. I do not have any financial disclosures to make. Now, artificial intelligence in medicine is increasingly becoming popular more in areas of cardiology, radiology, pathology, etc. And it is mainly based on two parameters. One, the numerical data like the heart rate, respiratory rate, etc. Or it could be image based like the CT or the MRI images or pathology slide images. Now, in ophthalmology, it is very popular already for diabetic retinopathy, retinopathy of prematurity, and is somewhat being used in oncology. Now, if we look at ocular oncology, retinoblastoma is one of the most common cancer that we see in children, and more than 50% of the cases present with advanced disease because there is no routine fundus screening that is performed in newborns or later in childhood. Over the years, we have gathered a large image data bank of capturing fundus images of all children who present with retinoblastoma. So we thought, why not use these images to develop an AI model for diagnosis of retinoblastoma. So the purpose of this study is to explore the utility of artificial intelligence and machine learning for diagnosis of retinoblastoma, and if detected, whether we can develop a model to classify the intraocular retinoblastoma. So the method that was used were the RetCam images were extracted first and they were labeled manually by two experts, and these same images were fed into the machine, and using various algorithms an AI model was developed to identify retinoblastoma. So whenever such an image is fed into the computer, it should be able to identify as a normal fundus. If such an image is fed, then it should be able to identify that this is a group A tumor. If a larger tumor, then a group B tumor. If associated with localized seeds, then group C tumor. If associated with diffuse seeds, a group D tumor. And if it is an extensive tumor, a group E tumor. Multi-label classification model was used for identification of the optic disc and tumor by developing a bounding box with confidence interval, and the machine was taught that optic disc size is 1.5 millimeters, so the tumor size was compared to the optic disc size to measure the tumor, and whenever the optic disc was not visible, the machine was taught that the circle within which the tumor is present, it measures approximately 12 millimeters. The seeds were identified by using OpenCV algorithm to identify the potential region of interest, and once the potential region of interest is identified, a deep learning model is used to identify the subretinal and the vitreous seeds. So the AI model was ultimately trained to identify the optic disc, the tumor, the size of the tumor, the distance of the tumor from the disc, the presence or absence of seeds, and the distance of the seeds from the tumor. An image analysis was done on 771 images of 109 eyes, of which 78 harbored retinoblastoma, and there were 31 normal eyes. The manual analysis was done by two experts, and there was good agreement between the two experts. The inter-observer variability when it comes to individual images was less than 1%, but the cumulative classification when the inter-observer variability was 0%. That is, each eye had a minimum of 4 images and a maximum of 20 images. For example, if such an image is shown, then this would be called as normal, but if a different quadrant of the same eye is seen, there is a tumor with a seed, so it would be labeled as group C. Then if we go to a different quadrant, we see that there are more number of seeds, so this will be classified as group D. And in another quadrant, there is a larger tumor with diffuse seeds, so this would be a group D tumor. So the cumulative classification would be that this is a group D tumor. Using the AI model, the accuracy in detection of retinoblastoma was 95%, and classification as per group was 85%. The missed diagnosis was noted in 3% cases, over-classification in 9%, under-classification in less than 1%, and misclassification of normal as retinoblastoma in 2% cases. So overall, the sensitivity and specificity for detection of retinoblastoma was more than 94%. The specificity was more than 90% for all the groups, while the sensitivity ranged between 63 to 100%. So in conclusion, AI model is a promising tool in diagnosis of retinoblastoma, and it may be useful in classification of intraocular retinoblastoma. The strengths of this study is that this is the first AI model for RB. It can serve as a useful retinoblastoma screening tool, and it has very high sensitivity and specificity for detecting normal versus retinoblastoma. Of course, it has limitations, like this AI tool was developed by feeding only the normal and the retinoblastoma images. We did not feed the other pathology into the system, so we are yet to do that. The sensitivity ranged between 63 to 100%, and there was unequal distribution of images in each group. The future plan is to increase the sample size and use other machine learning models to improve accuracy. The ultimate goal is that we should be able to screen the fundus images and identify which are the normal eyes and which require referral. For example, if this image comes, it should be termed that this is a normal eye, and if such an image comes, it should be identified that this eye has retinoblastoma and should be referred immediately. Thank you very much.
Thank you, Dr. Swati. Very nice study. Can I request Dr. Kasturi to make a comment?
Very beautiful study, Swati. Very nice. I have a question. You have mentioned about the image-based data. So what is the algorithm that you have taken for every patient?
So every patient, the fundus photos were fed into the computer, and they were mainly the computer algorithms that were used. It was the OpenCV algorithm, which was mainly used in most of for most of the parameters, and deep learning model. These were the two parameters that were. These were the two algorithms that were used to identify the various parameters for a fundus photo. So the parameters that were studied, as I elaborated, were presence of the optic disc, the tumor, yes or no, then seeds, yes or no, and what is the distance, what is the size of the tumor. So these were all the parameters that were studied.
And you mentioned it's a very nice screening tool. So will it accept only the RedCam images or image of any iPhone or many other device that I see people using it?
Yeah, thank you. I think that's a wonderful question. So we are right now looking at various parameters, whether the different machine captured fundus photos, what is the difference in identification, the different races as well, like Caucasian versus Indian race, if there is any difference in identification of the tumor and other parameters. So all these are ongoing studies, and we are also working on developing a low-cost, non-mydriatic camera to see that if we can provide a low-cost, a model to capture the images and then use those images and see if it can serve as a screening tool.
What is the possibility of a false positivity?
So as I showed that there were few cases, like there were 2 cases where it was normal, but it identified as that there was retinoblastoma. And when we went back and saw why there was so, it was mainly because of the artifacts that were there in the picture. So false positives is a possibility, but it was in 2% of the cases.
The reason I raised this question, because the diagnosis has implications.
Yes.
If you're going to use it as a screening tool and a false positivity comes, and that is going to have a lot of implications in terms of, again, re-examining and confirming the diagnosis.
Completely agree.
Actually, we did a similar study on using AI for detecting infectious keratitis. So we had a hell of a problem teaching the algorithm the difference between an active infiltrate and a scar. Because anything with so much size and of that particular color, it would detect as an infiltrate. Correct. So we had to do multiple retraining of that particular model to somehow, identify an infection from a scar. And as we speak, this article is in press in the IGO. So as an extension of Madam's question, anything on the retina or in the vitreous cavity, for example, uveitis or a CRA patch from a 2-dimensional picture, it will compare it with those pictures which you fed it and diagnose it as, retinoblastoma.
That will be the major.
So the point that I'm trying to make is maybe in pediatric populations, these general diseases will be less.
Yes.
Okay. But if a few of them are there, then false positives is what you may really be worried about rather than false negatives, as an extension of what Madam tried to point out.
Completely.
This is what I thought was very important. Confounding pathologies would be the major test of the screening device.
Yeah, so we had that problem even in corneal ulcers, from scar to ulcer, it could not differentiate very easily.
Yeah, completely.
Just regarding methodology, 3 questions. One is, you have a data imbalance.
Correct.
You have more of, very less about 31 normal. How you handled that for the deep learning? Because you don't have, the numbers are different. What you did for that.
Correct. And even that's why I put it in the limitations as well, because if we see the distribution in group A, B, C, D, and E, there is a disparity. There were more number of...
handled to get the AUCs, you must have handled by some way. You generated more images, what was the way?
Yes, correct. Yeah, so using those same images itself, more images were generated to train the model. And that's how we, right now we have, actually this data that I presented was the initial data. We have worked further after that, like we have almost doubled the numbers, and we have worked further on that to correct that imbalance. So that we will be publishing soon. Thank you.
So So the next presentation will be by Dr. Pallavi Joshi, and on the other side will be Dr. Rolika Bansal.
Good afternoon, everybody. At the outset, I would like to thank everybody, esteemed jury. So I'll be speaking about the learning curve in the construct of a smartphone-based keratoscope prototype for keratoconus screening. No financial interest. We all are aware that keratoconus is a progressive ectatic disease, and advanced stages have only option of surgeries. So early detection and treatment to arrest this progression and prevent the vision loss is very essential. So the need of study is India. Actually, when you see the keratoconic population is extremely high because of the thin and steep corneas as well as the irritations and eye rubbing. Investigation modalities used for screening, usually the Placido-based like Keratron to that of Pentacam, are all non-portable and are very expensive. So early diagnosis with respect to these machines actually becomes inaccessible to majority of middle and lower income. So with this in our mind, our institute planned a collaborative study with software professional, and we made an attempt to create a smartphone-based keratoscope prototype, and we developed did a validation of a diagnostic model called Smart KC. So in this study, what we analyzed was the steep learning curve with respect to the device, the prototype per se, the image quality with respect to it, how we could convert and change things in the Smart KC app, and last about validating this with a standard gold standard like the Keratron machine. So this is our Smart KC which I am showing. I have a small prototype to show also. So here, the first thing we had the challenge was what Placido's design we use. As we all are aware, the ellipsoid one is very bulky, whereas the planar actually cannot occupy the peripheral, only takes the central. So our final picture was just a conical thing which we took, which had 28 points, 360 degrees, which gave nearly 1008 point of capture, and hence we utilized that as the Placido's design. When we got this, we had other issues like the working distance gap. As you can see, the distance between the cornea and where the machine sits, this is the gap top. Any subtle change in the way it sits can cause either the cornea to look very steep or it can make it look like flat. So we get erroneous reading. So what we did was we went ahead with a simulation model with our software people, and they created a sphere, used the same light parameters which are used on the keratoscope and the machine, and did multiple revisions to find out, and came out with a regression formula which was applied after taking these pictures so that this gap error is totally taken care of. So with this, we thought we did, and we went ahead, but no, we had issues like tilts and offsets. Here we knew that we had taken 28 points, so if by chance the image was turned downwards or upwards, we used to get steeper areas which were closer. So for this, we came up with the introduction of a plus Meyer into the app, which would make sure that the quality check is done even before the picture is taken. So here I'm just showing you the video of our Smart KC. So this is assembly. This is actually a machine. What is important here is ours is a very cost-effective machine. This, a small paper. This is a butter paper of 2 rupees. This is a 3D model of nylon material, which is just prepared with a ring inside this, and we have these LEDs which are put. The total cost of this comes up to just 2,500 rupees. And after assembly, it is attached over the eye, and these are the rims, as you can see, the internal, which give very clear Meyers over the cornea. This is how the workflow is. It is an app which anybody can use. Here, our single trained optometrists were using, entering the patient data and taking into consideration of the picture obtaining through that. So what is the speciality here is, the image would not be captured until the quality check is done in real time. It is not later that the alterations are done, but in the real time you can see this red mark, which only once it shows that the image is good, then only the capture is taken, otherwise it is self-deleted at the same time. So this is how the picture is taken. So exposure, sharpness and offset is considered. Once this is done, this is the pipeline. What we do is, once the picture is taken, we go through the imaging, that is the cropping of it, then enhancement and the Meyer detection. After this, using the basic concepts of optics, that is the angle of reflection is angle of incidence, we use these 2 steps, that is the arch step method and the surface creation by Zernike polymers, by which we create the cornea. Then using the same form, what is used as the simulated K color maps are created, and we come up with a heat map through this machine. once we did this, the litmus test was whether this machine is capable of screening as equal to a standard keratron. So we did this by taking the patients, and we went ahead with one cases, and we found out that there was nearly 100%, 92% of specificity, and we had issues when the SIMK computing was wrong. There was a movement error here, so the SIMK was taken initially for 5. Once it was corrected to 3, we got repeatable images as similar to that of keratron. So this is our results. Many studies have been done, but our study is a real-time study where we have even the heat maps coming up. Limitation is, though we have done it, it is in a number, but it is a big number of nearly 57 eyes. And though we have used a single machine, we are hopeful that it can be used on any camera with 12 megapixel availability. And we need to try it with a little bit of more people who can use it. So to conclude, this study highlights the learning curves in a construct of the optical prototype, and it has a very good sensitivity and a very better specificity than the keratron machine. Hence, it is a good screening device for picking up keratoconus. Looking forward, we are trying to go and modify this more. So thank you. I would like to acknowledge the team, and these are my references.
Very good, Dr. Sri Ganesh.
Yeah, nice presentation. I just want to know, how did you ensure fixation?
We have done, fixation was ensured by using the principal axis and the reference axis, sir.
Yeah, but does the patient have a target to fixate?
Yes, sir, there's an internal
There's
target.
an internal target. Is it a light that he can see?
Yes, sir, there's one small cross that the patient can see through.
Cross, is it visible?
Yes, sir, yes, sir.
How did you reconfirm that the patient is fixating?
We are confirming by seeing that the picture that gets aligned there. They have seen that the patient is fixating, only then the capture will be, that is being modified in the app, sir.
Okay. And what about angle kappa? Can you measure angle kappa? Because that is one of the big fallacies.
Yes, yes, sir.
If you have a large angle kappa,
yes, sir,
then you can get skew.
Yes,
and
surely.
when you have skew, it diagnoses it as keratoconus.
Yes, yes, sir.
Okay.
Yeah.
So that is something that has to be taken care of. So if your device is not measuring that, that can be a problem.
Yeah.
And ensuring fixation, because the patient is looking up or looking down,
yeah,
then you can again get asymmetry.
Yeah, that's what I told you about the tilts, sir. That is how we assessed.
tilt,
we had issues and fixation issues. Both of it
Tilt
was corrected.
you can get with the device,
Yes.
or if the patient is moving the head.
Up and down.
But apart from tilt, if he's looking it in another direction, when you're capturing the image, if you look somewhere else, so probably you need gaze tracking also to be incorporated to be sure that he's fixating properly. That is one thing. And then angle kappa. Otherwise, you can have, these are the fallacies.
Yes, yes, sure. But we compared it with the keratron, sir. The same patients, when we did the comparative this, the pictures are coming the same. So probably it is not the direct evidence, but definitely in indirect evidence, the image is captured as much as clear as we do it on the keratron.
So, Dr. Pallavi, I have, some reservations on this, because okay, the intention is very nice and you've captured it very nicely, and congrats for coming till this stage.
Thank you.
But the thing is that an asymmetric bow tie, number one, is not always an indication of keratoconus. Skewing, asymmetric bow tie, skewing under a particular limit can be there in normal population as well.
Yes.
These days we detect very early keratoconus based on changes in the posterior cornea.
Yes.
So even for a screening tool, just because you're seeing asymmetric bow tie, that is not a detection of keratoconus. And if you want a screening tool, retinoscopy works even today very well. So you will be able to see doubling of the retinoscopy or doubling of the Myers in retinoscopy even in today's context. And if you are not going to address the thickness of the cornea or the posterior cornea, a screening tool may not be really that valuable.
Thank you, madam. Just to add a point here, actually, this is the initial learning curve. Basically, the paper what we presented is the construct learning and what issues we had and how collaboration with the biotechnology and the engineers helped us out. We are actually into the second phase where we are including the PPK as a part of this, and we are using the AI and deep learning where we are trying to come with an algorithm where we can include, where we can actually pick up the early, late, and delayed. But yes, as a screening, we may not be able to do the forme fruste where we look for the posterior floats and the pachy. But just to imagine, even if this gives us a picking up of around 20% in the which we are not picking and whom we keep doing DALS and PK, it would be still a screening tool. That's the intent behind the study.
Yeah, as an early detection of keratoconus, it is not ideal because see, the epithelium masks the early changes on the anterior
Definitely.
surface, so you need to look at the posterior curvatures also.
Yes, yes.
And you need to look at epithelial maps because they are more sensitive. Epithelial thinning can be one of the first signs over the keratoconus. And these are things that you cannot see with this because it's equivalent to a Placido disc, essentially. And you're using software. The same software, if you're an experienced surgeon, can look at it through the, and like the retinoscope is a wonderful tool because you can get early scissoring and you can pick it up. So whether this will have practical application for screening is a question mark.
Yeah, our intent is mainly for the school screening where we can use it along with, and we are doing the vision and retinoscopy. So maybe we are also doing on the retinoscope with the same thing. So we'll collaborate everything and try to come with a better screen too.
Dr. Joshi, congratulations. Just one quick question.
Yes,
what was the time of scan?
Time of scan, how long it took to do one eye. Around approximately, it was a single data collector, so it took around 10 minutes maximum with a little learning for the patient.
Your Myers are going to get distorted with the tear
No,
film?
no. So I meant the whole process, not the capture. Capture is in just a matter of 5 to 10 seconds, madam. That's all.
All right. Thank you.
Thank you, judges. So our next presenter is Dr. Rolika Bansal. May I request Dr. Simar Rajan Singh to be on the dais?
Yeah. Good evening, everyone. So I'll be today talking on improving local tumor control in conjunctival melanoma by adjuvant plaque brachytherapy. We have no financial disclosures. Conjunctival melanoma is a rare, lethal malignancy with an incidence ranging from 0.4 to 0.8 per million. Previously, several studies have been done with variable treatment modalities, including primary surgical excision with or without cryotherapy, adjuvant radiotherapy, enucleation, exentration, as well as genetics-guided targeted therapy. However, it has been seen that the lesions have had a tendency to occur again. That is a local recurrence of 19% and with a cumulative local recurrence of 37% at 10 years. Similarly, commenting on the mortality, melanoma-related lymph node and systemic metastasis have shown to be 25% each, with the melanoma-related death as 37%, which is quite high. So we tried to think about, is there a conservative approach possible where we just focus on precise primary surgical excision with cryotherapy and adjuvant radiotherapy? Primary plaque brachytherapy here included imaging guidance, and secondary plaque brachytherapy was HP guided. And keeping in mind that high rate of local tumor recurrence is related to high rate of metastasis, we came up with a novel multimodal management wherein 15 patients of conjunctival melanoma with scleral or corneal stromal invasion with no baseline metastasis were taken over. We observed a variable clinical presentation wherein the patients had dark pigmented flat lesions or elevated lesion or with a prominent feeder vessel, intrinsic vascularity, scleral fixity with corneal involvement, which was proven by imaging, that is ultrasound by microscopy, showed evident scleral invasion, and here you can see intraocular extension too, which was confirmed even by AIOC. Histopathology showed pigmented lesion with full thickness involvement, spindle to epithelioid atypical cells with cytoplasmic melanin pigments, and pigmented lesion with base involvement. So here we had proven imaging and histopathology guided scleral invasion and corneal stromal invasion. Our demography showed an age range of 8 years to 65 years, which is quite a significant range. And most of the lesions were arising from primary acquired melanosis or a nevus. The tumor diameter varied from 4 to 17 mm, and the tumor height was 1.5 to 6 mm. Here is a case of a 65-year-old male with extensive spread with recurrent conjunctival melanoma who was excised twice previously and was in the AJCC staging of CT3C. Here you can see that the surgery was performed with clinically clear margins, 4 mm were kept clear, and since the lateral rectus was involved in this patient at the insertion level, which was proven by MRI, the lateral rectus was disinserted and resected, lamellar sclerectomy was performed, and the lesion was excised completely. And along with that, any residual lesion that was left was also excised of the sclera. The lateral rectus was duly reinserted and the hot plaque was placed, and 2 rotations were performed in this patient considering the diffuse involvement. The plaque was removed as per the calculated dosimetry. And after the duration of removal, the edge and base cryotherapy was performed, which took care of the residual tumor at the edge and the base level, and following which surface reconstruction was performed with amniotic membrane graft, and a symblepharon ring was duly placed. So this, in our cases, we saw that the plaque, we used plaque as notch or round, and the dose, apex dose was kept as 10,000 centigrade with a depth of 2 to 3 mm, and the dose duration ranged from 11.5 to 74 hours as per the calculations. We saw excellent local tumor control. So here is a patient with an extensive tumor with at 8 years has no local tumor recurrence, alive and well with no evidence of metastasis. And this was the patient with the greatest dimensions, and the patient has complete local tumor control. So as per the AJCC staging, majority of our cases were in CT3A, and we had 100% local tumor control, vision salvage, eye salvage, and life salvage, even when 20% of our cases had further extension. So the previous studies have shown that a multiple variable radioisotope approach has been taken in, wherein strontium, yttrium, and iodine and ruthenium have been variably used. And they have seen high levels of recurrence, as well as the survival rate being 76.3. In fact, it was a range of 26 to 78%. And in our study, we had a more targeted approach where ruthenium was used for all our cases, which were image-guided evaluated and histopathologically confirmed, and at an 8.1 years of mean follow-up with by following a multimodal management approach of complete excision, adjuvant plaque brachytherapy, cryo to the edges, and histopathological confirmation, we had excellent local tumor control with 100% vision salvage, life salvage, and eye salvage. Thank you.
Yeah, wonderful, Rolika. Nice showing those difficult cases and treatment. Any comments, Dr. Grover or Dr. Kasturi?
Beautiful presentation, Rolika. I just want to know about the vision before and after the procedures. You have mentioned 100% vision salvage.
Yes.
So any compromise in the vision, or did the vision deteriorate, or it was same before and after?
So, ma'am,
and also the effect on the intraocular pressure.
Right, ma'am. Thank you, ma'am, for the question. Ma'am, we did not observe any of the intraocular pressure variables. In fact, the vision drop is considered significant when it drops by two lines. We did not have any of such observations in any of our patients. So vision remained within a within a one-line variation from the baseline vision.
Excellent, excellent study. Would you once again repeat the minimum and the maximum period of follow-up and the mean period of follow-up?
So the mean period for follow-up was 8.1 years, and the minimum has been 1.5 years.
Shall we go to the next?
Thank you.
Next presenter, judges. So the next presenter is Dr. Simar Rajan Singh. Over to you. May I request Dr. Sharon De Souza to be on the podium. Thank you.
Good evening, everybody. My topic for today is safety and efficacy of 27-gauge lens-sparing vitrectomy for stage 4 retinopathy of prematurity. I have no financial disclosures. Lens-sparing vitrectomy has been established as the standard of care for stage 4 ROP. It initially started as a 20-gauge system with Dr. Mike Tracy introducing it, but now majority of studies report results with 23 and 25-gauge systems. 27-gauge LSV initial experience has been reported by 2 studies in a very limited number of eyes from Japan and from South India. 27-gauge has potential advantages of smaller incisions, better sealing, and these eyes are as it is smaller, so it may be better for them. There are lesser chances of post-op hypotony and bleeding potentially, and better dissection of the proliferation in ROP with the cutter tip being nearer to the retinal surface. So with these objectives in mind, we tried to evaluate the safety and efficacy of 27-gauge lens-sparing vitrectomy for tractional retinal detachment related to stage 4 ROP. It was a retrospective interventional case series. All patients who underwent 27-gauge lens-sparing vitrectomy for stage 4 ROP between September 2019 and 20 were recruited. Detailed preoperative and intraoperative data recording using standardized performers was already done at the time of the surgery. So this is the performer that we routinely use for ROP surgery, which includes the preoperative features as well as the detailed surgical notes, including those for any complications that are encountered during the surgery, as well as the recording of the surgical times. So the primary outcome measure was single surgery anatomical success rate at 3 months, and secondary were iatrogenic complications such as lens touch or retinal break, wound leakage, requirement of sutures, postoperative hypotony and bleeding, and the surgical times of the entry time and the vitrectomy time. So this is just a representative case as to what was done. This was an 8-week-old infant presented at 40 weeks post-menstrual age, born at 32 weeks. Presented with stage 4B ROP in the right eye and stage 4A in the left eye. Both eyes underwent laser initially, as we do for most cases that present to us prior to surgery. And this is the short video clip of how we go about the 27 gauge lens sparing vitrectomy. The entry is made at about 1 to 1.5 millimeters from the limbus in the pars plicata region. And after securing the infusion, the other 2 active ports are made, and you can realize that even with these smaller gauges, the area available is so less that they are abutting the eyelid margin. And you can see the traction that is extending from the optic disc right up till the crystalline lens and actually attaching to the crystalline lens. The objective of ROP surgery basically is to dissect the vector planes and remove the traction, and not do a very extensive surgery of removing the hyaloid and trying to dissect all of the fibrovascular proliferation. So after the ridge to the disc to the lens traction has been removed, the rest of the vitreous is debulked as much as possible around, so that there is no future development of proliferation. And that kind of finishes the surgery, as partial fluid air exchange is done to tamponade the ports, and a majority of the cases we did leave sutureless, as there was no wound leak noted. So this is the same case post-operative 20 days. We can see the right eye that has settled now, and it further settles even better, and the left eye did well just with the laser. So 27 gauge initially had a lot of problem with flexibility, and we were using the Constellation system, but with the introduction of this 27 plus, which has this kind of 1 millimeter sleeve right at the junction of the shaft and the handle, which reduces the flexibility problem, and this is available with the 10K cutters, and we were very much more comfortable doing the surgery with this rather than the 7500 cuts cutter. So we had 44 eyes of 31 infants. 10 infants underwent immediate sequential bilateral lens sparing vitrectomy, and the mean age at post-menstrual age at surgery was 42 weeks. Prior to the surgery, laser was done in almost all the eyes, and anti-VEGF was given in 18 eyes, 11 of them as a part of the treatment of ROP, and 7 as part of pre-op treatment when they were vascularly active. And vitreous hemorrhage and pre-retinal bleed were associated in almost 1/4 to 1/3 of the cases, and majority of the cases had more than 6 clock hours of fibrovascular proliferation. Lens sparing vitrectomy could be done in all the eyes with 27 gauge instrumentation. 41 eyes had a minimum follow-up of 3 months, and 73% of them had a favorable outcome. The median follow-up was 8 months with a range from 3 to 18 months. Lower gestational age and higher stage at diagnosis were important factors causing unfavorable outcome, and they are present in even for most of the ROP cases. The average procedure time was about 30 minutes, and the vitrectomy time was 18 minutes, and sutures were required in about 1/3 of the cases. Complications, there was lens touch in 2 eyes, as you can see here, and post-operative fresh bleed, which was the most common complication in about 1/3 of the eyes. But most of them cleared by their own, and only 2 required resurgery for loose blood. And very interestingly, the factors causing loose blood, none of the eyes which had received prior anti-VEGF developed loose blood, so they were independent of the gauge of the surgery used. So coming to the conclusion, 27 gauge appears safe and effective in the management of stage 4 ROP. It provides the advantages of a smaller gauge without compromising on the surgical outcomes. Thank you.
Thank you. Any comments, Dr. Meena?
It's quite surprising to see that with an efficient ROP screening protocol in place, there are so many patients who require surgery.
Absolutely, ma'am. It's still astounding.
And what is the duration of your follow-up for these children?
Ma'am, the median follow-up is 8 months that we have, with a range from 3 to 18 months.
Did any of your children develop cataract during this time, except for the 2 cases where lens touched?
One more patient besides those 2. Both of them developed cataract and ultimately, but that was not in the initial period, so we could monitor them. And ultimately, when they developed cataract, they did undergo cataract surgery. But we did, since there was focal touch in the periphery, we preferred not to do a complete lensectomy at that point of time.
Great, very good study. Just wanted to know, because you said that you document the same ROP for all.
Yes,
Did
sir.
you find difference between 25 and 25 plus? Because theoretically 25 plus, or even we see diabetics, it is more useful.
Yes,
you
sir.
want to shave. Here your aim is not to shave the vitreous.
Absolutely.
So what added advantage, because you told outside still it is a big instrument. Inside you are just doing a little bit of truncation, you're not going as membrane peeling which you do in diabetics.
Yes.
So what additional advantage 27
So 25, a lot of, so this is not a comparative study, so I can't make a direct comparison on the basis of this. That is something that we have planned. So 25, a lot of cases require sutures. We were mostly doing a small peritomy in those eyes and then putting the instruments and then suturing them up. That requirement was greatly reduced with 27 gauge, as majority did not leak. So that was the major advantage that we felt with 27 gauge.
Can I make a quick comment? It is basically in relation to the suturing in children, because the globe rigidity is so different from the adults.
Absolutely.
Any opening in the eye, it is better to suture rather than to leave it. It is a general impression of an anti-segment surgeon. I think even when you enter an eye with even with a needle or a 1 mm keratome, we tend to close that because they behave totally different from the adults. And even though you mentioned in the video you have not sutured, almost 1/3 of them needed suturing.
Yes, sir.
So it is not that you are avoiding suturing by doing the 20 gauge.
No, ma'am, that is, we are not avoiding. Where it is required, we are definitely putting them. But yes, the need was reduced.
Okay, thank you.
Thank you.
Thank you very much.
The next paper will be presented by Dr. Sharon De Souza. May I request Dr. Nina R. to be on the podium. Thank you.
Good afternoon, everyone, to my esteemed judges and the audience. It's a pleasure and honor to be here. Today I will be talking about the effect of cap depth in SMILE on various factors in the eye. I have no financial disclosure in the public matters of this. So we all know that in refractive surgery, the corneal nerves can be transected, and corneal nerves have a very important role to play in how the eye heals. So we're always looking to see which, it sort of highlights in our mind which surgery, LASIK does more nerve transection, SMILE does less, PRK, we don't know. So we're trying to compare it. But what is established now for a fact is that definitely in SMILE, the nerve transection by the lenticule plane, which has been created, is less. So, and following that, the re-innovation is higher after the SMILE compared to the other refractive surgery modalities. So, over time, there have been multiple studies which have shown that this nerve preservation and regeneration is much better. But what is an important point to keep in mind is whether this fact of whether the nerve regeneration is faster, the nerve regeneration is better, does it clinically correlate and translate into a better healing and a better outcome post our surgeries? So this diagram just shows that even though we know that the SMILE, the cap, both the anterior and the posterior incision which is there does cut various parts of the nerve plexuses, and we wanted to know whether we can achieve a better nerve preservation if we do a deeper cap depth, because we know that many of the main subbasal nerve plexus is a little more superior. And also, if we are doing a deeper cut, we are closer into the stroma, we are closer to the density of keratocytes there, are we inducing more inflammation, and would that also affect the outcomes in these patients? So the knowledge gap we were trying to assess here is whether there's more, a change in the nerve regeneration, whether this would translate to a difference in inflammation, and overall how it would impact our wound healing. So this is our research question that we were trying to assess. In this patient, we had all patients who were undergoing SMILE. The age group was 20 to 30, and it was a prospective randomized study, and it was a contralateral eye study in which one eye had a cap depth of 100 microns and the other eye had a cap depth of 150 microns, which was randomly assigned. The usual exclusion criteria, which we use for refractive surgery, including any abnormal topography, dry eye, severe dry eye, scarring, were taken as our exclusion. So this is the kind of workup which again is quite routine, except for the addition of a confocal microscopy to assess the nerves. We also looked at the optical quality in great detail. The dry eye evaluation is part of our routine workup, so that was followed, and the tear factors to look for the inflammatory markers. And all of this was done preoperatively and at 1, 3, and 6 months to compare how these eyes were doing. All the surgeries were performed by a single surgeon on the same platform, same cap diameter, lenticule diameter, and the energy settings and laser parameters were also similar to avoid any confounders between the two groups. These were the outcome parameters that we looked at. As I was saying, the visual acuity and the quality of vision we compared. This was done by the optical quality analysis system. We also looked at the nerves by the confocal microscopy, in which we looked to see how the density and the features of the subbasal nerve plexus were. The epithelium is very, very important because it gives us a good measure of how the wound healing is happening, and if there's any irregularity preoperatively, that was also not taken. And the dry eye parameters by the Shermer's T-bud staining and the tear molecular analysis, which we did by the ELISA. So coming to our results, it was interesting to note that at 1 month, the group which had a 150 micron cap depth had a slightly less amount of dryness as compared to the 100 micron cap depth, although no patient in this group developed a severe dry eye. However, this difference reduced significantly over the 3 and 6 months, which means by 6 months, most of the patients were comparable across the two groups. So it was only the initial change which was significantly different. Again, what is quite reassuring to note is that the visual acuity, both the quantity and quality of visual acuity and the epithelial thickness, the epithelial changes were not significant between the two groups, whether the 100 or 150 micron. Again, even the biomechanics did not show any difference, which is again heartening to know. Even if we are cutting deeper into the stroma, the biomechanical strength at follow-up was very good in both the groups. Here's where we really wanted to add some value. If we have seen a change in their dry eye parameters, how can we explain this? So the subbasal nerve plexus density actually showed that there was much better preservation of the nerves in the 150 micron and a much faster regeneration of the nerves as well. And this could be one of the reasons why the initial dry eye is a little less in the 150 micron group. Interestingly, there was not much of difference between the inflammatory profile again of the 100 and 150 microns, but what was seen was in the deeper group, there was a change in the extracellular matrix modulators, and this could then be correlated to the fact that it's a deeper cap. So the dissection in the deeper plane could change the wound healing response. However, as we saw, the clinical correlation to this is that by 6 months, they're both doing very well, and that is really heartening. There have been excellent papers which have shown that the different cap depths have a very good clinical outcome. This is what we saw, that the early nerve regeneration is there in the deeper caps. I'll just close with this. So even though we know that the subbasal nerve density is good, we did see that in the 150 micron group, they reached much faster, so their recovery was a little closer. And how we can apply this in our results is that because the 100 micron group had a little more dryness in the initial phase, there was a little change in the inflammation. Maybe, we can look at the clinical surrogate markers, and in a patient who has a pre-existing inflammation or contact lens user, or we are suspecting they may have dry eye, we opt for a slightly deeper cap depth. Thank you very much for a patient listening.
Thank you, Sharon. Dr. Srignesh.
Yeah, nice study. We had done this study and published it in International Ophthalmology. And we also found that at the 160 cap, the early dryness was less in T-bud, but by 3 months there was no difference. I wanted to know whether you had any nomograms. Did you change any nomograms between the 160 and 100? Because there was another paper that was published. I don't know the institute, which says that you can have undercorrection if you go with a thicker cap, and so you need to have a nomogram adjustment.
No, sir, we did not do any nomogram just for this. It was similar across and just based on the refraction.
Did you do any energy adjustment? Because again, when you're going deeper, the corneal fibers are thicker, and so you may have a need for more energy to cut these.
And
otherwise, you can
no,
have
sir.
difficult dissection.
No, sir, we didn't. We kept the same energy.
You kept it at the same energy.
Sharon,
And you said you did OCT. So did you look at Bowman membrane distortion? Because with a with a thinner 100 micron cap, you can have more Bowman's membrane distortion than at the 150 cap. So did you look at it?
We did look at it. It's not part of the study, but we did look at it because we had the similar thought process. But we didn't see too much of distortion between the two groups. It could be, of course, that it's the same surgeon doing, and that the ironing and all is part of the routine protocol. But there was no significant difference between
Did you find
the
any difference
distortion.
in the OSI between the two groups?
No, sir. That I showed. No, not there. So we expected all of it, but nothing significant, which is great.
So very nice correlation of various aspects that you put together between the two levels of the cap. So is it even significant to consider the deeper stromal plexus, or is it too far away that it will not play any role whatsoever between the two levels of flap?
No, ma'am, that's a very valid point. So at 150 microns or 160 microns, some fibers or the trunks of the deep plexus could also be transected. The only point there is that because they are much fewer, we may not always, get them in our image repeatedly. So measuring them becomes a little more difficult.
So I was just thinking that we should not save something and hurt the other thing inadvertently.
But it won't be the main trunk. It will be
and it's probably not as relevant in dry eye causation as the subbasal plexus.
Yes, ma'am. Thank you.
Dr. De Souza, you have said that both the groups had a similar outcome at the end of 6 months.
Yes, sir.
So should we shift to a 150 flap now for all cases?
No, sir. There's really that's what we were trying to see, whether there's any reason to shift to for all cases, but there's no requirement for it. Sometimes if we have a
150 will give you advantage. If you have to do a resurgery in those cases, you can do a re-smile. Or you can do a flap-based LASIK also, thin flap LASIK.
Yeah, but what we did see was that some of the extracellular matrix factors were, more proliferated in the deeper cap. So we don't know if over time, long-term follow-ups, if they may have some change. So, but we'll stick to our original.
Corneal biomechanics did not show any change because as per the mathematical modeling by Dan Reinstein, if you have a thicker cap, then you're preserving the anterior lamellae, which is stronger,
more contributing
so you expect
to
a better biomechanics.
But
there was no difference.
No.
Thank you, Sharon.
Thank you.
Very good study. Let's have the other.
Thank you. The next presenter is Dr. Neena R. And may I request Dr. Mehul Shah to be ready on the podium. Thank you.
A very good afternoon to one and all. My topic is acute acquired comitant esotropia precipitated by excess near work during the COVID-19 induced home confinement. No financial interests. Acute acquired comitant esotropia is a type of acquired non-accommodative esodiation which is of sudden onset, often associated with double vision, but it is comitant. That means it is same in all gaze positions, seen in previously straight-eyed patients, could be smaller or older children, adults, and even in the elderly. Now, classically, 3 subtypes have been described. The Swan type, which occurs after a period of interrupted binocularity, the Berean-Francis T type with minimal hypermetropia and double vision, precipitated by physical or psychological stress, then the Belchevsky's type, which is seen in myopes with convergent spasm and divergence paralysis, then the previously missed high hypermetropia, which can be adequately controlled with refractive correction alone, and the lesser common entity of an intracranial pathology manifesting as an esodiation. Now we know that with the COVID-19 pandemic, with the new norm of work, study, and play from home, life has changed tremendously. A total of 320 million learners in India transitioned into e-learning, with the global number of workers rising to about 558 million. These are people working from home. So with this increasing dependence on gadgets for studies, work, and leisure, we found a substantial increase in number of young adults and children coming to a hospital with recent onset of inward deviation and double vision, which prompted us to do this study. So this was a retrospective study of all those with acute onset comitant esotropia from August 2020 to January 2021. So these were the diagnostic criteria. Age of onset was after 1 year, acute onset of esodiation within hours, days, or week, with photographic evidence of previously aligned eyes. The parameters evaluated included demographic features, details of the history and the near work, and a complete ocular evaluation including an atropine refraction. Ancillary investigations like an orthoptic evaluation, imaging and systemic evaluation were also done. So these were our results. We had total 15 cases, 11 males and 4 females. Majority presented with double vision and squint, and the mean duration of presentation was 2.98 months. So you can see here the majority were above the age of 10 years, and most of them were students, 73.3%, and the rest were employed. There was no precipitating event other than excess near work in most of the patients, except one patient who had fever prior to the onset of esodiation. So you can see here, majority had more than 8 hours of near work, and the most common medium of near work in 86.7% was smartphones. And the most common near activity was online classes in 53.3%, office work in 20%, leisure or mobile games in 20%, and religious text reading in 6.7%. So hypermetropes were more common in a study, but interestingly, the myopes, 3 out of the 5 myopes admitted to doing near work without their glasses during the study period. The average ISO deviation was 22.73 for distance and was 18.73 for near. 11 of them had double vision on words for dot test for distance, though majority maintained good stereopsis for near. So orthoptic evaluation was essentially normal. Coming to the management, all those with pre-existing or newly detected refractive errors were given glasses. All those with or at risk of amblyopia given occlusion therapy. All were advised to restrict and reduce their near work, especially on mobiles. Those with divergence insufficiency were given exercises or prisms, and this was usable in 5 patients. All those with basic type of deviation were advised surgery, and 4 underwent surgery, as you can see here, and regained good binocularity and cosmetic alignment. So we had 4 categories of patients of AACE. Myopes with divergence insufficiency ISO deviation, which could be classified as a Belchevsky's type. Low hypermetropes with basic deviation. Then the occasional low hypermetrope with divergence insufficiency. And 1 patient which could be classified as Burrian-Francisci type. But the only common factor in most of them was excess near work, either on smartphone, laptop, or books. So when we did a literature search, we found 1 or 2 studies in the past of AAC in patients who had smartphone use of more than 4 hours per day. We had earlier reported a retrospective analysis of children who did very well with surgery and timely amblyopia management. So this is probably the largest series we are reporting in the COVID pandemic. So what is the etiology? Increasing use of smartphones and tablets in modern life has led to more and more near work and play done at close distances, leads to an imbalance between accommodation and convergence, with a naturally stronger convergence in the younger population overtaking it, leading to a dynamic activation of the medial rectus muscle and development of a manifest esodiation. And this effect is greater in hypermetropes due to the greater accommodative demand. But even a myope can develop an esodiation because they tend to hold text close to their face, and this leads to an increased tone of the medial rectus muscle, coupled with a lack of distance stimuli, leading to divergence weakness and again a manifest esodiation. So continuing glucose, home confinement, and work from home policies have led to important lifestyle changes in the young population. A lesser but more troublesome side effect would be acute acquired comitant esodiation. So I would say that parents and public health authorities should take serious note of this negative impact on the eye health of the young population and make suitable recommendations and regulations to mitigate this undesirable effect. So these are my references. Thank you.
Thank you. I think it's a wonderful presentation, especially looking at the COVID situation and having these patients to have these type of features. Any of the judges wants to make comment on this?
Just one question. Did you look at the nutritional status and did you do a nutritional assessment? Because that could also...
No, because I work in Cochin, and I work in a tertiary eye care center, and the profile of patients coming to us, they have pretty good, reasonable nutritional level.
Overnourished.
I could say overnourished.
That's also part of malnourishment. Overnourished.
Actually, we started the study because we saw a lot of patients coming to us with double vision and invert squint, which was, that is when I decided to look into it, and that is when I decided actually to do this study.
Okay. Thank you. Thank you very much.
Thank you so much. The next paper will be presented by Dr. Mehul Shah. May I request Dr. Manisha Agarwal to be on the podium for the next?
Good afternoon, judges, contestants, and friends. I will be presenting my study on the new mathematical model for the prediction of visual outcome in younger children with mechanical ocular trauma in comparison with the other models. As we all know that trauma is important cause of mechanical blindness, monocular blindness, and visual outcome is unpredictable because of comorbidity. The social impact is very much, and financial impact also is approximately 77 billion, 29% out of which is because of children. And these are the further challenges in the children, but most important challenge is the amblyopia, which has been overlooked in many studies. So there are existing predicting models. One is the ocular trauma score proposed by Kuhn et al. And CRT that is present, but nobody has validated this study with the larger prospective manner. So we tried to study this and published this in one in ophthalmology and another in JCRS in 2011 and 2012. And then we tried to look at the particular pediatric ocular trauma score, which is to be studied with particular important factors to be included in this study. And that is also discussed in LAJO, in Ocular Trauma Study Review article. So why the toddler ocular trauma score? In case of toddler 0 to 6, visual assessment on present may not be possible, which is the primary base for ocular trauma score or pediatric ocular trauma score. So Reed et al., which has published the article based on clinical finding, calculation of trauma score, but he has included 0 to 18 years on and only in open globe injury. We tried to study these in all 0 to 6 toddlers and included open and closed both injuries. So this was the prospective cohort study with the ethical clearance, and we excluded all children who has not followed up for 6 years. The information is collected on a pre-tested online format using the ISOT form, and OTS categories were high risk to low risk, and pediatric ocular trauma score category from high risk to low risk were compared with the toddler ocular trauma score, which was 5 to 1. And ROC curve ROC curve was used to look at the sensitivity and specificity as comparing all three scores. To ease out the statistical analysis, we merged the high risk cases and low risk cases in two categories, and those are studied. Score calculation, as we know, according to Kuhn et al., this was the primary row score, and these are the condition, particularly globe rupture and endophthalmitis, perforating injuries, retinal detachment, they were deducted. But in pediatric cases, in pediatric ocular trauma score, we considered two more factors. One is the age. -10 was considered in amblyogenic age and wound location. The score calculation in toddler ocular trauma score was a wound size more than 6 mm, existence of hyphema, cataract and lens damage, choroidal detachment and detachment of retina. If sum was less than 1, it was good prognosis, and more than 1, it was poor prognosis. These are the result. 1630 total cases, out of these 681 were pediatric and 124 cases were the toddler less than 6 years of age. These are the age and sex distribution, and these are the 25% were the open globe and 75% almost was the closed globe patients. So mean age was 4.6. When we consider pre and post vision, different was significantly. When we studied the open and closed globe, we did not find any significant difference, and children less than 2 years had a significant poorer outcomes. So when we compared actual and predicted, we found these are the percentages in ocular trauma score and pediatric ocular trauma score, and these are the area under ROC curve which are documented. If we look at the high risk category, we could not find much of a significant success in TOTS, while if we consider the better group score 3, 2 and 1, we found the significant area which has covered, so which shows the high specificity and sensitivity. And we compared these parameters, and this parameter we find that with the high risk score, it was not effective. So this is the comparative summary of 3 models, And conclusion is toddler ocular trauma score is a novel predictive score which is more reliable than the POTS but less specific and sensitive in high-risk cases. This TOTS can be employed to examine the outcome in toddlers in whom vision checkup is not possible at presentation. Thank you.
Thank you, Dr. Mehul. Nice presentation. I think I can request the Trauma Society of India President, Dr. A.K. Grover sir, to comment.
So Dr. Mehul, this is a good study, something that has not been done for toddlers earlier. But would you again give us the relative benefits as compared to pediatric ocular trauma score that this particular score is providing?
When there is a ocular trauma, it is extremely difficult to measure the visual acuity in these children, particularly when it is 0 to 6. So it is better to detect them from the objective finding rather than subjective finding. That is the main purpose.
So what benefit has this given over the pediatric ocular trauma score?
There is a misjudgment of the visual acuity that might lead to the false prediction of the POTS. POTS also we have validated for 700 cases. So we have.
What was the age group used in POTS?
0 to 18.
Okay.
This was 0 to 6. This particular age group was targeted, which was not even done by Reid et al., who has designed this TOTS. He has designed for 0 to 18.
So eventually, what benefit do you think it will give us?
Basically, we look forward that objective finding, if we define the score, then it will be more reliable than the which is based on primary visual acuity.
Thank you.
Thank you, Dr. Mehul. Very nice. Thank you.
So the next paper will be presented by Dr. Manisha Agarwal. May I request Dr. Komal Agarwal to be ready on the podium for the next. Thank you.
So good evening, everyone. My study is correlating intraocular VEGF levels with prompt clinical regression of TB granulomas treated with anti-VEGFs and moxifloxacin. Tubercular granulomas are the most well-recognized phenotypes of intraocular tuberculosis. These are hypoxic granulomas associated with increased levels of VEGF. VEGF is said to be a known biomarker for active TB disease, both pulmonary and extrapulmonary. The purpose of this study was to evaluate the intraocular VEGF-A levels in TB choroidal granulomas and correlate them with the clinical regression on treating with intravitreal anti-VEGF and moxifloxacin. The secondary objective being to evaluate the visual improvement in these patients. Ethical clearance and informed consent was taken. 10 consecutive patients with intraocular TB granulomas were enrolled in the study. Aqueous sample was subjected to sandwich ELISA test and VEGF-A levels were measured using human VEGF antibody pair kit test. Intravitreal injection of bevacizumab and moxifloxacin was given every week till the granulomas regressed. Systemic therapy in the form of 4-drug ATT and corticosteroids were continued, and a correlation was done between the VEGF levels and the clinical regression of these granulomas. 10 eyes of 10 patients were included in the study, out of which 8 patients showed choroidal granuloma and 2 patients, they had an optic nerve head granuloma. This is a table showing the decreasing levels of VEGF on subsequent intravitreal injections in these patients, and these tables are showing the clinical regression and clinical response of the TB granulomas on giving these injections of moxifloxacin and anti-VEGF. The primary outcome was that the mean baseline VEGF-A level was found to be 1,000 to 1,500 picograms per ml, which had drastically reduced at the time of last injection to 27 to 50 picograms. A prompt clinical regression was found in all the 10 patients within 4 weeks of starting these intravitreal injections, with an average number of injections being 3, ranging between 2 to 4. At baseline, 9 patients had a best-corrected visual acuity of less than 636, which had improved in 4 patients to a vision of 6.6, 2 patients with 618, and 4 patients with less than 624. This is one of the representative cases of this series, where a 24-year-old female patient with diminution of vision in the left eye for last 5 days and already on ATT for last 2 months for pulmonary tuberculosis. We see a large TB granuloma supranasal to the disc and also involving some element of the disc with cystoid macular edema in the macular area. At baseline, the VEGF-A level was 927, which had drastically reduced to 422 after 1 injection. This patient apparently did show a very good response of the TB granuloma, but developed a paradoxical reaction, which was treated with IVMP and stepping up of the oral steroids. This is the timeline of this patient, where the vision had improved from 636 to a complete recovery of 6.6 N6 vision at 2 weeks follow-up, with a total regression of the TB granuloma. This is another representative patient where you have a large TB granuloma involving the macular area. The VEGF levels measured were 1200, which had drastically reduced down to 257 after 2 injections of intravitreal moxifloxacin and anti-VEGF, and the vision had improved from 3/60 to 618. So TB granulomas are hypoxic granulomas with increased VEGF-A levels, which are said to be 4 to 5 times higher than that found in AMD-CNV patients. Patients with active pulmonary TB are found to have VEGF levels in the range of 700 to 800, while AMD-CNVM patients are said to have it in the range of 100 to 200. The half-life of intravitreal bevacizumab is said to be between 2 to 7 days in non-vitrectomized eyes, but it further reduces because of the breakdown of the blood-retinal barrier secondary to inflammation in these eyes. This is a representative cartoon of a TB granuloma where you have caseation necrosis in the center surrounded by macrophages, which are harboring the TB bacilli and surrounded by the abnormal vasculature. And what this abnormal vasculature does around the granuloma is that it leads to unequal distribution of the ATT drugs, reducing a multi-drug therapy to a monotherapy, and thereby increasing the risk of multi-drug resistant TB. Hypoxia also makes the MTB bacilli dormant, and as we know, INH is the only bactericidal antitubercular drug, but it does not act on the dormant bacilli, and it acts only on the actively multiplying bacilli. Thus, the need for innovative host-directed therapies. And what an anti-VEGF does, it decreases the hypoxia and thereby avoids the bacilli from becoming dormant and increases the bactericidal effect of INH indirectly. It also normalizes the vasculature of the granuloma, thereby increases the small molecule delivery of ATT and thereby decreasing the development of multi-drug resistant tuberculosis. Now, what is the role of moxifloxacin? It accumulates in the activated macrophages which harbor the MTB bacilli with a higher intracellular to extracellular concentration in comparison to other ATT drugs, and thereby helps in elimination of the MTB bacilli from the macrophages. The VEGF levels were measured for the first time in this study in patients with ocular TB granuloma. An effort to normalize the vasculature of the TB granulomas is done as quickly as possible so that the ATT drugs effectively reach the granulomas and regress them fast. It was a proof of concept study and hence the small number, and it was a non-randomized study and thus the limitations. So we conclude by saying that very high levels of VEGF are found in patients with tubercular granulomas. A monthly injection of anti-VEGF may not be enough to aggressively treat these vision-threatening TB granulomas. Weekly intravitreal injections of anti-VEGF and moxifloxacin given as an adjunct to ongoing ATT and steroids may help in faster regression of these granulomas. I would just like to acknowledge the contribution of National Institute of Immunology, which helped us in measuring the VEGF levels, and Professor Ramod Gupta for all our knowledge on ocular tuberculosis. Thank you.
Thank you, Manisha. Would you like to?
Thanks, Manisha. Nice study. Just wanted to know, so basically VEGF is secreted in cases of tuberculosis by the macrophages.
Yes.
And they secrete this VEGF. The purpose is to cause new vessels.
Right.
So that the immune, all the cells go to the tumor or to the granuloma to take care of it. Now you are blocking this VEGF. Do you feel that ATT may not reach enough now, because that's the only path through the blood? It is going through these vascularized channel. It is there in all other parts also, lungs also, they say that ATT activity reduces.
So that's a very valid question, but what we need to understand that because of the high VEGF levels, it's not the normal vasculature. It is actually the abnormal vasculature which is developing around the granulomas. And the abnormal vasculature is not having a normal structure. So rather than actually helping in the healing or in the distribution of the drugs, there have been histopathological studies which have shown that it hampers the equal distribution of the ATT drugs. And therefore, despite being a multi-drug therapy comprising of 4 drugs, it actually reduces being just a monotherapy. And that is what is the main underlying cause of multi-drug resistant TB, which is developing so rampantly in our patients. So that's really not something which is useful, which is happening in these.
VEGF, how you feel would be helpful in the clinical care? Because we know that definitely VEGF is more even in pulmonary.
Right.
It will be much more in the ocular one because of a vascularized
Right.
granuloma. What clinical implication this will have?
So, till now we never had the concept of treating these ocular TB granulomas with an anti-VEGF drug. This was just a proof of concept study where we wanted to highlight that the VEGF levels are much higher in comparison to our routine patients of AMD, CNVM. But what you say is the clinical implication. All you know, in future it may act like a biomarker, just to assess what is the activity of the disease still persisting when you're not getting a good response to your drugs.
You said you have to give the anti-VEGF every week.
Yes.
So how practical is it to give a anti-VEGF every week, and for how long do you have to give it?
So again, that's a very valid question, because being retina people, we are very used to giving a monthly injection, and that's what we all are used to. But the difference being over here that these are the patients who are not requiring more than 4 injections. And we have been now regularly treating in our clinics every week, and we see a beautiful regression of the granulomas. And why I want to suggest this is because if we are allowing a regression of these granulomas just to take place on systemic drugs like ATT and steroids, what we have been doing as a standard of care, the time taken for the regression is about 2 to 3 months, and it already causes so much of RP atrophy and scarring that the visual recovery is hardly there. The advantage what we are getting over here, even though we are treating them very aggressively by giving an every week intravitreal injection, is that the regression is taking place within 2 to 3 weeks. The limitation is that it's not an indefinite treatment that you'll continue for months or years. It's just requiring 2 to 3 injections, a maximum of 4. And in 95%, the regression will take place within 4 weeks of your treatment.
Again, rather than giving every week, can you think of a higher dose? Because if we know the maximum concentration is
Right.
within a week, and we know in some times of neovascular AMD, we give a higher dose of anti-VEGF.
Sure, that's a good idea. Maybe we can explore it in the future.
You're also documenting a lowering of the VEGF levels with the anti-VEGF. So don't you think you could wait a little longer before repeating the injections?
Ma'am, as I mentioned, we are in a great hurry because we want to even increase the efficacy of the ATT drugs, which is getting hampered by these abnormal vessels.
And what is the systemic ATT protocol that you're following?
We are using the 4-drug ATT for 2 months and then followed by 2 drugs.
Thank you. I stay corrected. The presenting author of the next paper is Dr. Subhadra Jalali. Over to you, ma'am. Thank you.
Good evening, judges and delegates. The purpose of my paper is to report the short-term treatment outcomes of a very novel surgical technique of combined scleral buckle and a modified scleral imbrication for ROP and other childhood onset very complex retinal detachments. This is a retrospective analysis of the first 24 eyes which were treated during the lockdown. The surgical technique I will be showing in the video. The anatomical outcome at the last follow-up was assessed. On literature search, we did not find any report of this procedure being done for this type of detachments. So last 30 years, I've been struggling with patients like this who've been following with me for many years, and then suddenly they come with a weird detachment of exudation, traction, reg RD, we can't see the break. And we've been doing multiple surgeries, 3, 4, 5 surgeries, landing up into glaucoma, keratopathy, and really not very happy with this. And we know that simple buckle doesn't work in these eyes. The reported success is between 30 to 40%. So when I looked at the literature, I was very happy to note that somebody has been doing this scleral buckling imbrication in Oregon Medical School, and that it was the preferred surgical procedure. But recent literature does not talk about it, and it was done only for reg RDs. The recent literature only talks about imbrication without any buckle, but along with vitrectomy being done for myopic schisis. So we'll go to the video.
The muscles and clearing the sclera of all the tenons, a horizontal incision is given at the site where the maximum traction is. Usually this would be the equator, but it can be anterior posterior to it. And then I give 2 vertical incisions on the sides, create 2 flaps up and down.
So no new instrument is used, the normal instruments which we use in our routine. We didn't have to order anything more.
And then suture these with non-absorbable 5O ethibond or 5O Dacron sutures and make it very tight.
So the modification we have done is that from a spindle shaped thing we have converted into a square flap. And I was pleasantly surprised. The globe becomes very soft as soon as you remove these scleral flaps, and you can really imbricate it very tight. I didn't expect that. And that's it. I mean, any retina surgeon can do this who has been doing buccal, and there was nothing very, exorbitant that I had to do. It was just convincing myself that this will work. So the duration of this study was during the lockdown from 2022 to 2021. Almost all these cases are under our IRB approved databases. 24 eyes, mean age at the time of surgery was from 3 months to 14 years, mean was 6 years. The most common primary etiology was ROP, followed by FEVR and persistent fetal vasculature. And many of these eyes had either a combined reg and tractional RD or along with exudative detachment. All these eyes were not fit for buckling because we could either not see the break, or even if a break was suspiciously seen, it did not match the topography of the egmatogenous detachment that we saw. The follow-up was good from 6 weeks to 2 years. Most of them have more than 3 months follow-up. The beauty of this was at a single surgery, the retina showed complete attachment with no progression in 19 eyes, and an additional eye with silicone oil surgery and silicone oil removal was successfully attached. So it doesn't prevent us from doing the vitrectomy surgery if in future we want to see it. There was no intra-op or post-op complications except for transient raised intraocular pressure of about 13 in 2 patients, which was controlled with topical medication, and this was tapered over 3 to 12 months, and now all patients are off medication. The visual acuity was really gratifying in these children because a lot of them got good visual acuity and wherever it was able to record. So the pictures will speak for themselves. You can see these very complicated detachments, single surgery, retina is flat, patient doesn't need to come for repeated EUAs and repeated surgeries. This is a 4-year-old child who had aphakia because of a unilateral eye, which I had done surgery for stage 4B ROP, and then suddenly the parents said for last 1 week he's not seeing. He has a total detachment with such a abnormal looking retina, and you can see after surgery he's back to school at 2 years. The indent of that imbrication is seen very well on the post-op B scan. The most exciting thing that I found with this surgery was that the posterior fold actually opened. Somebody asked me, will it open? And I was surprised that just with an external procedure, the whole fold has opened up. And then I realized it's like a paper boat. If you press it on the sides, the bottom will open up. And here we have children where if you do vitrectomy, you would just be lost. But our work doesn't end with just attaching the retina. I think the real work of a retina surgeon is to, demonstrate that there was a detachment, it has attached, the things are very good, they're not going to come back. And the most important is to put them back to life. This child after surgery was written by the ophthalmologist at his local place that he is unfit for Navodaya Vidyalaya, where he got admission and should go to a blind school. We did his low vision aid testing. He's 20, 50 and 8. Completely fit, and this is the certificate we have given that he's very fit to carry on his studies, and we are talking to the principal every 6 months on teleconsult, reassuring them that this child need not go to blind school. So ladies and gentlemen, I just share some old wine in a new bottle. I'm sure that many of the retina surgeons will get hooked to this procedure.
Thank you, ma'am. Thank you.
Excellent case. Can you just suggest what is the mechanism, how it is acting? It's basically imbrication, buccal or scleral shortening. All of them are producing more buccal height. So what you feel would be the mechanism of action?
So as you saw, and this is in the literature also, as you saw in that patient with the whole fold open, we are compressing the globe on the sides. It is a closed funnel, and it's actually flattening the bottom. And you can see that here also, that the whole sclera becomes flattened. That is one part. Second part is because there's a shortening, if there was a suspicious break, and because I'm putting a buccal, so I'm putting buccal either 42, 240, 287, depending on the pathology. If there's any other area, like there's an exudation, I have to do cryo, it will cause contraction. So all those things are taken care of. The unknown breaks, the tractions, the multiple areas of exudation. You do hemangioma has a break. You have to resect, do retinectomy.
Breaks, though you have opposed it, but you have not created a pixie around it.
I do. If I can see something, I create a pixie. But that is the beauty, that even if you don't create a pixie, you don't know where it is. But the height is so much that it goes somewhere in that height and the fold. So it doesn't leak.
I have a question, Subhadra. You are using non-absorbable sutures. So do you feel the need to cut the sutures when the child grows up to let the globe grow back normally?
So actually that was the question happening in ROP babies, that, do we need to incise those, cut the buccal and all, and I was doing that for many years because the literature said so. But there was no evidence that we have to do it. And what happened in last 10 years, there were many patients, because they are outstation, they never came for that cutting. And when they came at 7-8 years, they are perfectly fine. And now there have been some publications which are really questioning that do we really need to cut that, because some of them redetach. So I think the thinking is we follow them. If we find something happening, we can always cut it.
Wonderful paper. I just have one question. Is there a difference in the actual length? Have you measured it before and after the procedure?
So we have some data. I have not presented that, but on the refraction side, it creates about 2 to 3 diopters of myopia, but not in all patients. Some patients, it didn't create any myopia. Thank you. Thank you, everyone.
Thank you very much.
That was the last presentation. So with that, we conclude the Colonel Rangachari session. We thank our judges for their patient listening to all the excellent presentations. This is the top of the nation presentation and the highest award that can be conferred. So all the best to all the participants, and let the best ophthalmologist or the best scientific research win. The judges just need to hand over. They need not put the total. That will be done by the tech team. They just need to hand over the signed score sheet to the hall coordinators. And for your efforts, we are providing tea to you.